Hi, everybody. I'm Kathleen Digre. I'm the director of the Center of Excellence in Women's Health, also distinguished professor of neurology, professor of ophthalmology, and adjunct professor in OB-GYN. And I want to welcome you to now our fourth Sex and Gender Conference here at the University of Utah and the Center of Excellence for Women's Health. And we're thrilled to have you all here to celebrate Women's Health Week this week. The Sunday, and the whole week after Mother's Day is designated as the National Women's Health Week in the United States. And that's what we're here to celebrate. And the way we like to celebrate it is to talk about sex and gender differences that affect all of us, men and women, health. And we often use as our backdrop the 7 domains of health. As you know, we promote that health is more than physical health. It's emotional and financial and social and environmental and spiritual and environmental, etc. And we promote that in all of our programming. We have an amazing program for you today. And I want to just start off by thanking Dr. Nancy Lombardo for our library partnership with the Eccles Health Sciences Library, who's recording our proceedings today. And these proceedings will be posted in our new journal, which has been with us now for 1 year, the Women's Health, the Utah Women's Health Review. And I'm going to ask Dr. Katherine Schliep to also say a few words as well. And I also want to thank Leanne Johnston, who all of you know by now is the person who sends out all the invitations, makes everything happen. And we are so grateful for both of them. And I also want to thank the COE committee for all the hard work everybody did in putting this program together. So I'm grateful to Dr. Karen Frost in social work, Dr. Nikki Mahopoulos in pediatrics and internal medicine, Dr. Michael Varner from OB-GYN, and several other of you on this who can be on the screen today. I want to thank you also for participating and help us come up with the program. And in particular, I want to thank all the speakers for recording their talks, helping us get all of this together. I don't know, has Dr. Silver joined us here yet? I don't think so. So if he's not here, I'm going to introduce Dr. Karen Schliep. Dr. Schliep is the editor of the Utah Women's Health Review. She is also a professor in the College of, or in Family and Preventive Medicine. And Dr. Schliep, please take us through the journal and tell us about this amazing resource that we have here at the University of Utah that all of you in the audience can use.
This will be just a short overview of our successes this past year. As Kathleen mentioned, we launched the journal just 1 year ago. And this is a collaboration between Eccles Health Science Library along with the University of Utah Center of Excellence in Women's Health. So we have a very easy website to remember, uwhr.utah.edu. And as you can see across, it's a very simple way to navigate between looking at past issues, and we are receiving open submissions. So as articles are peer reviewed and then those that are accepted immediately go online, our submission site, that's for both authors interested in submitting, finding out the instructions, as well as reviewers, which we're really welcoming additional reviewers to be a part of our journal. We have a really nice issue search button. You can find all of you who are presenting today can go in and see your names. You can search also by topic, and then a little bit, we've added a new tab, or about is about the 7 domains and our editorial board. And we have a new tab under resources to try to help potential authors with resources that they can visit for ideas and for help in their submissions, writing up their articles. So as I mentioned, we are open submissions. The Utah Women's Health Review is a peer-reviewed journal. It is published for free. There are no fees associated with publishing your articles. And as Kathleen mentioned, we are focused on sex and gender differences that affect the 7 domains of health: physical, emotional, environmental, financial, intellectual, social, and spiritual. And this is, if you do go into our About, we do ask authors to identify one domain or a few domains that are tied with their articles. And so you can learn more about these 7 domains that really represent a state of complete physical, mental, and social well-being. So this is, the Utah Women's Health Review is an ideal place for your students, residents, fellows, and faculty to publish their research. And while the journal, while we showcase the work of local researchers and clinicians on the health of the Utah population, we accept submissions from across the state. We've reached out to other universities and other entities that we think might be interested in submitting or in reading our journal. And we also accept submissions from beyond Utah. This is a good example is, folks who are doing national studies. Well, they might take just that Utah component and publish it in our journal, even if a larger article will be published in a national journal. But the key is, as long as we focus on women's health of sex and gender differences. This is also a great place for students, residents, and fellows to get ad hoc journal peer review experience. I've had many of my students that are in training review for this journal, and they could put it on their resume or their CVs. So if you're interested in that, we have the link here at the bottom for just email. If you have questions about the submission process or about the articles, or you would like to become a reviewer, please do email us, or we have a nice Twitter account in which we actually have tweetable quotes for each of our articles as they're published. And we do accept original research, review articles, data snapshots, and commentaries. So this has been a year of growth. As many of you know, the first edition, inaugural edition of Utah Women's Health was done in June 2007. And then Jessica Sanders, there was this idea of kind of a decade later doing another issue, and this was published in May of 2019 and appeared on our website during the launch of our journal in May of 2020. And then we have the full symposium. Our wonderful editorial assistant, Allie Moore, has done closed captioning and has all of the last year's symposium available. And then, of course, as I mentioned, we have rolling articles. So as those articles are accepted, we go ahead and put those online. We have citations. All the publications have their own DOI. The other really nice thing that we've had is that we can actually, we've had 2 of our 3 original articles now cited in or indexed in PubMed and searchable via PubMed, as long as there's any public funding, NIH, ADRQ, some type of public funding you can associate with that research. We can help assist you in getting those PubMed indexed, which I think is really wonderful. We have several articles and commentaries currently under review that we're wrapping up, and our hope is to publish this issue 2 this month, and along we will then have also this symposium after it is finalized, also available as its own issue. And then finally, I just wanted to point out the resources tab. This is a nice presentation that was done by a wonderful Utah Department of Health analyst who was able to go through step-by-step how to use IBIS for anybody who would be interested in coming up and writing their own Utah data snapshot. You can turn to this video and get a step-by-step process on how you go about obtaining data. So just in closing, we've had a great year, particularly given COVID. We're proud of what we've done, but we really look forward to receiving more submissions from all of you, and additionally, having any of you that are interested in reviewing for us do so. So thank you.
Thank you very much, Karen Schliep. So the way this is going to work, we've pre-recorded the talks, but each author is going to be there to answer questions. It's my great pleasure to introduce Dr. Katherine Hayes, who's an assistant professor in OB-GYN. She's fellowship trained in pediatric and adolescent gynecology. She's come to us from all over the world, even Landstuhl, Germany, and her research focuses on improving care for patients born with congenital anomalies of the reproductive tract. And thank you, Katherine. She's part of our planning team, and she's going to talk to us about pediatric and adolescent gynecology, what you really want to know. So let's hear from Katherine.
Thank you for that kind introduction. I want to take this opportunity to thank the organizers of this symposium for inviting me to share pediatric and adolescent gynecology, what you should know. Here is my obligatory disclosure slide declaring that I have nothing to disclose. Many of you are probably asking yourself, what exactly is pediatric gynecology and why is it important? You're not alone, as many practicing physicians and advanced practice providers have never even heard of pediatric gynecology. Pediatric and adolescent gynecology, or PAG, is a rapidly growing field. It was first established by Rudolf Peter in Prague in September 1940. However, the first faculty positions were not established until 1962. The North American Society for Pediatric and Adolescent Gynecology, or NASPAG, was founded in 1986. More recently, the number of fellowship programs here in the US have continued to grow, with 12 programs currently and a 13th about to be added. In 2018, ABOG, our certifying organization, created a focused practice designation in pediatric and adolescent gynecology, further solidifying the unique care provided by PAG physicians the world over. We provide the full range of gynecologic care from birth until the 18th birthday. PAG practices, especially those situated completely within children's hospitals, do not routinely provide obstetrical care, although some PAG fellowships do include clinical exposure to teen OB clinics. Gynecology touches so many aspects of the lives of those assigned female at birth that we participate in a large number of multidisciplinary clinics to bring our expertise to the patients. Here at Primary Children's Hospital, I participate in the CHARM, or colorectal, Hirschsprung, and anorectal malformation clinic, the DSD, or Disorders of Sexual Differentiation clinic, the Joint Hematology Oncology clinic, as well as clinics with our oncologists, including cancer survivorship and hereditary cancer syndrome clinics. We also plan to join Spina Bifida Clinic, IBD Clinic, and Turner Syndrome Clinic as our program grows. Pediatric gynecologists perform a wide variety of surgeries. Procedures include reconstructive surgeries for Müllerian anomalies, laparoscopy for pelvic pain, ovarian masses, and adnexal masses, removal of vaginal foreign bodies, examinations under anesthesia for prepubertal complaints, and complex surgeries in multidisciplinary teams for anomalies such as cloacas and DSDs. Pediatric gynecologists also provide gender-affirming care to our transgender and non-binary populations. Today, I'll briefly touch on a common complaint seen by PAG providers, as well as some topics that are more up and coming in the field. Throughout this talk, I will use the terms female, girls, and women for simplicity, but please know that the subjects I'm discussing also apply to non-binary and trans patients who are assigned to female at birth and have typically female reproductive structures. Vulvar care has been in social media headlines quite frequently lately. In March, Vagisil launched their OMV line that you see here that is marketed towards teenagers. Several gynecologists on social media, including some pediatric gynecologists, went after the company for marketing an unnecessary product towards teen girls, an already vulnerable population. My most favorite line from all of this, quote, "Your vulva is not supposed to smell like a pina colada," end quote. Vaginal and vulvar complaints are a huge part of a pediatric gynecology practice. just as it is for my adult colleagues. In our younger kids, we see a lot of vulvar irritation due to the things that we see here, like bubble baths, bath bombs, leotards. The most frequent presenting complaints are redness, irritation, and discharge. These complaints are frequently misdiagnosed as yeast infections, and kids are treated with multiple rounds of oral and topical antifungals, like the fluconazole seen here, before presenting to gynecologic care. A good rule of thumb is that if you're out of diapers and haven't hit puberty yet, it's not yeast. The pH of the vagina is not favorable for yeast at that age. A patient with a culture-proven yeast infection in this age range should prompt further evaluation for diabetes and/or other immunocompromise. Teens also often present with complaints of vulvar irritation or vaginal discharge. Just like in younger kids, these complaints are often hygiene-related. Society makes girls feel like vaginal discharge is not normal, despite it being very normal, and so teens are often trying to eliminate oral discharge. Commonly, teens will wear panty liners every single day to try to absorb all the vaginal discharge. Liners are so irritating though, and because of this irritation, the body often produces more discharge in what becomes quite the vicious cycle. We also discussed the important role the pubic hair plays in protecting the delicate vulvar skin. If I had a nickel for every time I told someone to use a bland topical emollient, think things like Vaseline and Aquaphor for their vulvar complaints, I think I would be a millionaire. My 8-year-old daughter actually asks me almost every day how many people I told to use Aquaphor during clinic on that day. Now we're going to shift to a new and exciting service that the team is excited to be able to provide soon within the Intermountain West. Each year, about 89,000 young people aged 15 to 39 are diagnosed with cancer. We refer to this group of patients as AYA, or adolescents and young adults. In addition, about 10,500 children under age 15 will be diagnosed with cancer each year. As our therapies improve, many more of these patients are surviving past 5 years and becoming adults. As patients live longer, the early and late consequences of cancer management are beginning to assume greater importance for survivors, their families, and their providers. When considering the long-term sequelae of cancer therapy, infertility surfaces as a primary concern, particularly among female survivors. Additionally, fertility concerns are not limited only to cancer patients, but also patients with medical conditions such as rheumatoid arthritis and lupus, as well as those patients with disorders of sexual differentiation and gender dysphoria. Traditionally, female cancer patients who wanted to have their own biologic children in the future had limited options, such as protecting the ovaries from radiation and emergency oocyte cryopreservation. While shielding is routine, not all patients may be eligible for oocyte cryopreservation. Ovarian tissue cryopreservation opens up another avenue for fertility preservation for these patients. Most importantly, it allows prepubertal patients undergoing gonadotoxic therapies to have an option for fertility preservation where none previously existed. It also allows for postpubertal patients who cannot delay their therapy starts by 2 to 3 weeks to have an option for fertility preservation. As of 2019, over 130 children have been born to patients who underwent orthotopic autotransplantation after previous ovarian tissue cryopreservation, including a patient who was prepubertal at the time of the initial tissue harvest. In patients with bloodborne cancers, it's possible to isolate immature oocytes from the cryopreserved tissue and mature them in vitro, followed by in vitro fertilization and embryo transfer. In the adult population, ovarian tissue cryopreservation is no longer considered experimental, although it is still considered experimental in our pediatric population because of the limited number of patients. Ovarian tissue cryopreservation requires a laparoscopy that is often combined with another surgical procedure, such as a port placement to limit the patient's anesthesia exposure to harvest one ovary, like that seen in the upper left corner of this slide. The tissue is then prepared in the lab and cryopreserved. The tissue is processed by an embryologist with cortical strips prepared, as seen in this slide. The tissue is then frozen. At a later date, it can be thawed and then auto-transplanted if there's no concerns for malignancy within the tissue, such as with blood-borne cancers. All right, sticking with the theme of ovaries, but transitioning from cancer to torsion and the prevention of future torsion events. In the pediatric and adolescent population, torsion is a rare event that usually occurs in the presence of an adnexal mass. However, normal ovaries do torse and are more likely to experience recurrent torsion in the premenarchal patient. Although the data is inconsistent, oophorectomy has been proposed to decrease the risk of torsion of a normal ovary, although no consensus exists to describe appropriate candidates or the preferred surgical technique. We are currently conducting a large multi-center retrospective study to examine the rate of recurrent adnexal torsion with and without oophorectomy to help establish best practices for this procedure. In our pilot data, 141 unique patients had a total of 171 torsion events. A total of 44 of those patients had either at least 2 torsion events and/or 1 oophorectomy, while 23 of those patients had a pexy completed after a single torsion, with no future torsion events. We identified 7 patients who had 3 or more torsion events. 5 of these 7 patients torsed both before and after a pexy. Our pilot data show an overall recurrent torsion rate of 15% and a rate of 17.6% after pexy. These rates are consistent with the small single-site studies currently reported in the literature. It seems that some patients retain the risk of torsion even after pexy, and this may suggest that the patients who repeatedly torse may benefit least from oophorectomy. There's a risk that in a patient who has previously had a pexy performed, that they will have an increased time to surgical care, as ovarian torsion may be lower on the differential when presenting to the ER. It is important to maintain a high clinical suspicion for torsion, even in patients who have previously had a pexy completed, especially those who are premenarchal at the time of their presentation. Finally, we're going to transition to a group of complex pelvic anomalies that should be of interest to adult women's health providers. Anorectal malformations occur in about 1 in 4,000 live births, while cloacal anomalies occur in about 1 in 20,000 live births. Many patients born with these anomalies will have normal reproductive tract anatomy. However, they are at an increased risk of reproductive tract anomalies. In less complex anorectal malformations, or ARMs, such as rectovestibular fistula and imperfect anus, a vaginal septum will be the most commonly seen gynecologic anomaly. In patients born with a cloaca, greater than 50% of them will have a Müllerian anomaly, with uterine didelphys being the most common finding. Around 10% of patients with anorectal malformations will have Müllerian agenesis, also known as Meyer-Rokitansky-Kuster-Hauser, or MRKH syndrome. These facts are significant for those providing adult gynecologic care, as the surgeries that are completed throughout infancy and childhood will have impacts on the care provided to these patients as adults. Most importantly, many of these women may elect to attempt pregnancy. The data is very limited, with only 1 paper published in 2019 really examining obstetrical outcomes. Currently, we counsel patients who have undergone a cloacal repair or a posterior sagittal anorectoplasty for imperfect anus to deliver via cesarean. Unfortunately, the counseling likely needs to be much more nuanced than this. If a patient is incontinent or only continent with a catheterizable stoma, a vaginal delivery may be a preferred route of delivery to protect the stoma that allows them to maintain social continence. Another important consideration in this population is the need for cervical cancer screening. Based on a survey we completed, adult gynecologists are less sure of the need for a PAP when a patient has a neovagina or non-native vaginal tissue. It is important to remember that all patients with a cervix require PAP screening within ASCCP guidelines, no matter what tissue their vagina is composed of. Patients without a cervix, but with a mucosal-based neovagina, may have cervical cytology screening completed, although the guidance on this is much more limited. Finally, Patients with colonic neovaginas require colonoscopy at the time of the tissue to screen for colon cancer. All of this is important because large numbers of these women are reproductive aged or are soon to become reproductive aged. Our survey showed that less than 15% of participants were familiar with the associated reproductive tract anomalies in patients with anorectal malformations. Less than 10% were familiar with Mitrofanoff and Malone catheterizable stomas, and the overall confidence of caring for women with ARMs was low. I want to thank you for listening to my presentation on pediatric gynecology. I'm excited to be here in Utah as a resource for all those caring for pediatric patients with gynecologic needs. Please feel free to reach out anytime to discuss or refer a patient. I'll now take any questions that you might have about my presentation or about pediatric and adolescent gynecology in general.
Thank you, Dr. Hayes. That was amazingly wonderful, and we are so glad you're here. If anybody has a question, just unmute yourself and ask Dr. Hayes. I would like to ask you, how do we get our patients into you?
Yeah, it's a great question. So if you have Epic, you can put a referral to pediatric gynecology through Epic, and those go, my office staff have a way to get those. If you are an Intermountain provider, you can put a referral in through Icentra. And if neither of those apply to you, you can fax us a referral at 801, I'll put it in the chat, 801-662-1715, or you can just call our office, 801-662-1717.
Put that in the chat for everybody, because we're so glad you're here in Utah. I mean, this is such a huge need, and it has not been covered before. So we're very, very grateful to you. Any other questions here? I'm monitoring the chat. Everybody said that was great, accessible. I also saw a note saying, I'm glad you covered the discharge, because nobody's talking about, and everybody should be. For adolescents. The problem is they fall through the cracks, right, for care. So any other questions?
Dr. Hayes, I'm interested at what age are most anorectal malformations diagnosed?
Yeah, so most anorectal malformations are diagnosed shortly after birth because they're imperforate anuses, or they have like a fistula and no eutopic anal opening, and so those are usually diagnosed within the first couple days of life. Although we have a kid who came through recently that wasn't diagnosed until 5 months of age, which is pretty late.
Well, thank you so much. We are going to move on to Dr. Deanna Kepka. She's another organizer of this conference, but more than that, this is a woman who knows a lot about HPV and COVID vaccine. Deanna Kepka is an associate professor in nursing. She's got tremendous research on HPV vaccine, and is going to be covering other information about COVID vaccine. So we are thrilled to have Deanna Kepka. Dr. Kepka will be presenting her presentation and then be available for questions afterwards.
Hello, everyone. Thank you so much for joining us on this lovely Thursday for our Sex, Gender, and Women's Health meeting here at the University of Utah. I appreciate you taking your time out of your busy schedule to spend some time with us and learn about our research in these areas. If you're watching this at a later date, thank you for making time. Even after the conference is over, we're happy we can provide some insights into some of the work that we're doing that may be helpful to you, or maybe you want to get involved in some of the work we're doing. So a little bit about me. My name is Deanna Kepka. I'm an associate professor in the College of Nursing. I'm an investigator at Huntsman Cancer Institute. I focus on cancer health equity research and the prevention of HPV-related cancers in the Mountain West, in the US, and around the globe. So I'm really excited to talk to you a little bit about some of the work that my team and I have been pursuing this year during the COVID-19 pandemic. So I would like to especially thank Sarah Mann and Kayla Christini for all of their efforts in launching this project and data analysis activities, and even in slide help for today's presentation. So You know what? When we look at young adults in the United States, we only see 40% in 2018 ever having received one or more doses of the HPV vaccine. Now, this is perplexing because the HPV vaccine has been around since 2006 for girls and since 2011 for boys. It's recommended to be delivered as part of the Adolescent immunization platform with Tdap and Menoptera. It can be given as young as 9. It's expected to be given by 12. If you receive the HPV vaccine at 13, it's actually considered late. But the vaccine can be given to young adults up through age 26. No questions asked. It's part of a recommended catch-up immunization schedule. And one of my passions for this work has been, let's improve HPV vaccination in the Mountain West. We are bottom of the barrel in the United States. We're less than the bottom quintile because you can see we've got quite a few color schemes here, and we are white as white. So we've got a lot of work to do, even across the United States. As of 2019, only 54% of adolescents by age 17 are up to date with the HPV vaccine immunization series. And by up to date, that means that they've received either 2 or 3 doses. It's a multi-dose series. Depending on your age, under age 15, you only need 2 doses. But in the Mountain West, we're even seeing much, much lower rates where we've got far less than half of our kids completing the HPV vaccine series on time, which means that by the time you're 18 in the Mountain West, there's a good chance that you haven't been vaccinated. And at age 18, you're in a position to make that decision for yourself. So we've been working on looking at HPV vaccination efforts that target young adults in the Mountain West. We have focused specifically on rural challenges because across the United States, as I told you, I focus on cancer health equity research. We're seeing up to 10% lower percentage point performance in HPV vaccination rates among communities that are rural settings. So if you're a rural young adult, you're much less likely to have completed the HPV vaccine series by the time you're 18 than if you're urban. And we know in our 5-state Mountain West region, we are largely rural. How are we doing in COVID vaccination? So given everything that we've been through over the last year, I've decided to look at, does some of these challenges in HPV also relate to COVID vaccine hesitancy? And once again, we are performing quite poorly compared to the rest of the country. This is a map that was just put out literally 2 days ago by CNN. We're seeing the entire Mountain West region, except for Colorado and New Mexico, having less than 44% of our adults being partially vaccinated. So that's not even necessarily completing the multi-dose series if you require the second dose for the type of vaccine that you got. So once again, we're performing poorly, and we've got a lot of work to do. And I am sure that these figures trickle down to the young adult population with even some lower vaccination rates. Because as you know, with COVID vaccination, often it's our older populations that have been targeted as the priority first. So what are some of the factors that relate to vaccine hesitancy? I'm sure not a day goes by that you haven't heard something about vaccine hesitancy on the news or in a discussion with a friend, social media. So the 3 C's are the 3 domains of constructs that have related to vaccine hesitancy in the past. And that's confidence in the vaccine, so it's trust. Complacency. Do you think you're at risk for COVID or HPV? If you don't really think you're that at risk, you might be complacent and not make it a very important priority. Convenience. Is it easy to get to? Is it easy to complete the series? And this is a greater challenge for rural residents where they have to travel further for healthcare. But some new domains of care factors relating to hesitancy include collective response. Like, maybe I don't think I would necessarily be hospitalized from COVID, but no, I don't want anyone in my family, any persons that are around me to be impacted by COVID. So because by protecting myself, I protect them. Calculation. So, what is your level of engagement in information gathering? Like how much are you interacting with news and other information sources related to perceived priority for this vaccine or factors related to hesitancy? So we conducted a survey originally for this study. We were funded by the National Cancer Institute as a supplement award from our Cancer Center Support Grant to look at rural cancer prevention and control initiatives in the Mountain West with a focus on HPV vaccination. Originally, we were going to do focus groups, but pandemic hit, so we pivoted and moved to an online survey platform. So we conducted a survey from October to April, and we only included participants who are ages 18 to 26. So these are participants who are eligible to make a decision for themselves about receiving HPV vaccine or COVID vaccine. So I definitely would like to thank Sarah Mann for her wonderful time spent on putting these lovely slides together. So here's our distribution by ages. So you see we have a lot of 18-year-olds, a lot of under 22-year-olds. We targeted many college campuses in the Mountain West, mostly female, but we still have a good chunk of male. We had 2,600 participants in the results I'm going to present today. We had responses, so we targeted the entire Western US, including Alaska. And I love this color-coded map where you can see, yes, most of our participants, 38% came from Utah, and that's because of our network of listservs here and it was pretty easy to access Utah respondents, but we still branched out and got respondents from all over the Mountain West region, including California, New Mexico, Alaska, Idaho, Wyoming. We really had a nice sample here. We also got a good mix of urban and rural. So the light blue is urban, the darker blue is rural by state. And then some folks lived in regions that could be considered rural or urban. And these rurality determinations were made by looking at participant zip codes and then mapping them to RUC codes, rural urban classification codes. And I greatly appreciate Kayla Christini's, my staff member, her efforts on this rurality classification. So we had mostly white respondents, pretty typical of our region, but we still had a good 20%, 19% of Hispanic respondents. So we're proud of that, and a mix of other races and ethnicities. So let's dig into a little bit of attitudes and knowledge. So how do people think about are vaccines a good way to protect yourself from a disease? And you see, yes, this enthusiastic yes, you see a disparity between urban young adults really thinking, yes, it can protect you from disease, and then fewer. So we're dropping from 95% urban young adults thinking that to a little bit more than 75% rural young adults thinking that. And this was statistically significant. In general, do you think vaccines are safe? We're seeing a similar pattern where more likely urban respondents think vaccines are safe. And keep in mind, these are only young adult participants. And do you think vaccines are effective? And again, urban participants are more likely to agree that they are effective. When we look at these other categories, I do not need vaccines for diseases that are not common anymore. So even, tetanus is not a very common disease, but it's lethal. So you look at differences in needing, perceived needing these different vaccines, whether or not the diseases are common. And you get a little bit of a disparity between what rural residents think, the dark blue, and what urban residents think, the light blue. So urban residents are more likely to disagree with this statement than rural. Are vaccines a good way to protect yourself from disease? And again, we see more likely urban residents agreeing with this statement than rural. And again, this is only among young adults in those Mountain West states. Are vaccines safe and effective? Well, again, we see urban more likely to agree that they're safe and effective. Is the HPV vaccine being pushed to make money for drug companies? And here you see disagreeing, we see rural residents are less likely to disagree than urban residents. And you can see a slight variation here where urban residents are more likely to agree or strongly agree than these other groups. So these are demonstrating higher levels of vaccine hesitancy among rural young adults versus urban in the Mountain West. So when we look at, do you trust these following persons regarding vaccination or medical information? So these are overall categories. We're looking at who matters when it comes to getting your recommendation and trusting that source. We see, 71% of our respondents trust their physician. 51 absolutely trust their provider, and 37% somewhat trust their provider. Health authorities, a slight dip, 62% yes, absolutely. Family and friends, we have more mixed reviews around family and friends. We have about 48% saying yes, somewhat. Government, we've got 8% saying absolutely not versus 47% saying somewhat they trust government. So again, like I predicted, we've got quite a few young adults in this sample, 47%, who've not had any shots. That means not a single dose of HPV vaccination, even though it has been around for more than 15 years for girls. We see disparities in girls, women more likely to have received the HPV vaccine than males in the Mountain West, and urban slightly more likely than rural young adults in the Mountain West to have received the HPV vaccine from this sample. So what are the main reasons you decided to get HPV vaccine? So we look at, some of the most important reasons are to protect your future partner or spouse's health, or your doctor recommend that you get the HPV vaccine. And we know doctor recommendation is one of the most important factors. And once again, you see disparities where differences between rural and urban in prioritizing HPV vaccination strategies. What are the main reasons you did not get it? My doctor did not recommend it. Well, here we see 36% of rural respondents saying their doctor didn't recommend it versus 27% of urban. So here's again, we see some disparities in why people did not get the HPV vaccine based on where they live. How about COVID? Have you delayed any vaccine because of the COVID-19 pandemic? And again, this is a little different. We see urban folks more likely to have delayed immunizations than rural. Has your doctor postponed HPV vaccination because of the pandemic? And again, we slightly see more urban healthcare teams postponing vaccination appointments than rural. Do you intend to get vaccinated against COVID when it becomes approved? So keep in mind that some of the participants in the study took the survey before the COVID vaccine was approved. And once again, we see more respondents in urban settings willing to be vaccinated against COVID than urban. And this is a huge difference, 71% versus about 49%. So I'm just going to touch on, I am the director of the Intermountain West HPV Vaccination Coalition. If you want to join our coalition, please email me after this, after you watch these slides. And you are welcome to participate in our monthly webinars where we bring the latest and the greatest HPV vaccination research to you. We focus on researchers in the Mountain West. We also focus on HPV cancer survivor stories and the perspective of healthcare teams trying to improve HPV vaccination in Mountain West settings. You don't have to join every meeting. You can join when you're able. We'd love to have you as part of our group. This is the region our coalition targets. It's quite expansive. We have tripled in membership over the last 6 years. And we're also we're recruiting right now clinicians in rural settings in the state of Utah to participate in a healthcare team intervention to improve HPV vaccination. And we were recently funded by Huntsman Cancer Institute and Intermountain West Healthcare Huntsman Cancer Institute and Intermountain Healthcare to do this. I'm so used to saying Intermountain West. Please contact me if you are a part of a healthcare team in these regions of Utah and are interested in learning more. Thank you so much. This is my son who got his HPV vaccine last summer. I was so proud of him. Age 11, he was super tough because he got all 3 of those vaccines that I told you were recommended for this age group. Here's my contact information. Please contact me if you want to join our coalition or learn more or are interested in some research activities that we are working on. Thank you so much, everyone. Have a wonderful day.
Gosh, Dr. Kepka, that was amazing. It's so important and important information for all of us with all the vaccines that are out there and trying to keep our country and our society safe. Thank you so much. We have time for a question if somebody has one. One question I have is, and Dr. Sanders asked this, thank you for the presentation. Given that both HPV and COVID have been politicized, how do you think these rates of hesitancy compare to other vaccines like MMR and flu? What a good question. Thank you for that question.
Thank you, Jess. Well, what I could say, can you hear me okay?
Yes.
What I can say is in the state of Utah, so Tdap and Menoptera, which is the meningitis vaccine, they're required for schools. So actually in our state, we see really high rates of Tdap and Menoptera, like 80 to 95% vaccination rates. And so and flu, we're not great at. I think we're like 50%, maybe less. So there's a number of challenges. I mean, there's the politicalization of HPV because it relates to sex, big deal, right? It's the most common sexually transmitted infection in the world. 80% of us will have it. It's like the common cold of STIs. So like the stigma continues to perplex me, but I know it's an issue we need to address all the time. And COVID, as you can see from what's happened this year, the political affiliations relating to public health initiatives and to supporting or not supporting them. And it's been really challenging. I find the United States to be one of the most interesting countries in the world right now when we see what's happened around just protecting public health. We have a free vaccine, COVID, that we've got less than 40% of our population in Utah getting it. And it seems like the needle's not even going to move that much around COVID vaccination. But I am so truly excited about the news that just came out yesterday from the Advisory Committee on Immunization Practices approving the COVID vaccine for ages 12 to 15. But not only that, they're approving for it to be delivered concomitantly with other adolescent immunizations. And the reason why they're doing that is because adolescent immunizations have taken the biggest dip in the United States this year as a result of the pandemic. So they're allowing HPV to be delivered at the same time as the COVID vaccine for kids ages 12 to 15.
That's great
Huge,
news.
really big news, really big opportunities for us and for my team and our coalition, anyone who wants to work with us.
That's really, really awesome news. So glad for that. Thank you so much, Dr. Kepka, and thank you for answering the questions in the chat. That was so great. You answered several questions that people had, and it put your contact information because other people may want to contact you about this very strong work. We're so thrilled to have you here at the University of Utah leading the way. With that, I'm going to introduce Dr. Rebecca Simmons. She is an assistant professor in the Department of OB-GYN and is in family planning. And thank you, Dr. Simmons, for talking about reproductive years, contraception, gender preferences over time. Sounds like a really interesting and important topic.
Hi, everyone. So I'm Rebecca Simmons, and I'm really excited to talk to you today about some of the work that our team in the Family Planning Division have been doing around the contraceptive journey. Before I get started, just a quick note to say that I don't have any financial disclosures to make at this time. Before I talk about my own research findings, I would like for you to take a second and just reflect on your own contraceptive journey. So, how many methods have you or your partner ultimately used over the course of your life? Why did you or your partner stop using a method? What were the methods that were your favorite? What methods really sucked for you or your partner? I think as you think about these things over the course of my talk, some of the findings that I'm going to present today will really make sense in the context of your own life. The reality of looking at contraception is that a person will stop or start using contraceptive methods an average of 10 times throughout their reproductive life. Yet the reality of this changing dynamic use is not really mirrored in the way that we tend to implement contraceptive initiatives, conduct research on contraceptive use, or talk to patients. To date, our approach has largely used method uptake as a primary outcome in research. This gets us to a certain point, but the argument that I would like for us to consider today is what we might be missing if we fail to consider the realities of contraceptive use and non-use over the life course, or what participants in a previous study conducted through UCSF coined the contraceptive journey. Some of the work that I do looks at contraceptive switching and discontinuation. So it was probably going to be inevitable I would start to think about how contraceptive use played out across the whole reproductive lifespan. To that end, my colleagues and I conducted a qualitative study of women in Utah, exploring this idea of women's contraceptive journeys and how experiences with contraceptive use subsequently frame future method decisions. And to do this, we recruited participants for this project from a previous project, the Her Salt Lake study, which is a longitudinal cohort study at the University of Utah. In total, we conducted 35 in-depth interviews via phone or Skype. And though Her Salt Lake included transgender and non-binary individuals, everyone we interviewed for this particular research project identified as a woman and heterosexual or mostly heterosexual. So I'm going to be using women in this talk, despite the fact that Her Salt Lake doesn't have all women identifying participants. So what did we find in these interviews? Women reported 5 categories of things that affected their contraceptive decision-making. Physiology, or how one's own body responds to methods, given things like pre-existing health conditions or experiences of side effects. One's personal values, including things like religion, feelings about sex, and pregnancy desires. Relationship influencers, including your sex partners, family, friends, and providers. Circumstances, including things like income, insurance status, education, age, and upbringing. And finally, experiences, including past experiences with different methods, with pregnancy, birth, and abortion, with past relationships, and with other experiences in life in general. Some of these categories are pretty well documented in the theoretical frameworks around contraceptive use, but what I'd like for you to consider today is their dynamic nature. Values change, relationships change, circumstances change, even physiology changes in response to external and epigenetic factors. And with all changes comes experience. And so as these factors change, women's contraceptive behaviors also change alongside them. We discovered that women's stories of contraception use were essentially centered around 4 touch points: the story of need, the story of initiation, the story of use, and the story of cessation. The contraceptive journey itself is an aggregation of all these stories combined and repeated multiple times over the life course. So I want to share 3 examples today that give context to these aspects that I've just told you about, influencing these different stories of need, initiation, use, and cessation. So this is an initial story around method need. I grew up LDS Mormon, and so obviously it was always abstinent-based. And I also grew up in Utah, so I never learned too much about contraception. So all growing up, I really didn't know about too many methods. And then my freshman year of college, which was in 2015, I was actually raped. And at that time, I was panicked and remember Googling. I was Googling questions like, how do I know if I'm pregnant and what's going on? I really didn't know anything. I started reading on the Planned Parenthood website and found a lot about contraception and things like that. And so then I was like, okay, well, probably won't ever have sex again for the rest of my life, so it really doesn't matter. But at least I know. And then as time went on, I obviously started having other relationships. I always wanted to use condoms, so I always used condoms. And then one boy asked, "Are you on birth control?" And I said, at the time, I lied and said yes, because I didn't want him to freak out. And the next day I went and got Plan B because that night we hadn't used protection. And then I was like, all right, this is a bad idea. If I'm going to be sexually active, I should have actual birth control where I don't have to panic about being pregnant all the time. You'll note in this story that a variety of values, circumstances, experiences, and relationship aspects are at play in this person's early experience with method need. And that interplay between these is complex and dynamic. One can see similar factors at play in a story of initiation. I decided that I didn't want to get any more injections, but I had to let them wear off. I had 2 more months, I think, so you couldn't really do anything about that. I just scheduled a time to get a meeting and discuss another option. I think I went back to the same Planned Parenthood and told them I didn't want to get the depot and told them why. And I told them I wanted to go back on the pill because I thought I was sure I was going to be able to get it a little bit more regularly scheduled. And they just would not take that as an answer. Yeah, they just thought that I should try something else. And in the end, I was getting really frustrated and I just wanted to leave. And then I got talked into someone ordering me the ring, and I really didn't like the sound of that much, but I thought maybe I could give it a try. But then that must have been right before Christmas time last year, and I left town and I hadn't picked it up, and I went home, and then I just decided I wasn't going to get it. I just decided that I was going to go off birth control for a while, which was actually going really well because I felt really good and I didn't have the headaches anymore or anything. And I know I could have tried other options, but I was just so happy to not be dealing with it for a while. So then that was last winter, and then I went through spring, and then I went partially through summer, and I was being careful using protection, but at some point in the summer, there was this slip up, and I ended up pregnant. As you can see with this person's cessation and initiation stories, they were wildly influenced by her interactions with her provider and her care team, as well as her experiences of side effects. I want to give one more example in the story of use. I felt awful. It was really painful to get it in. I think about it and it was like the worst pain I've ever felt. And my struggle with the IUD was that I remember looking up and I was just doing research and seeing they said you typically have bad cramps for 6 months or so. And I had really bad cramps for over a year. It was awful. And it would come randomly too. So for the majority of the time, I was always on ibuprofen. But I don't know, just eventually it went away. I was abstinent for a while when I broke up with my boyfriend, but when I started having sex again, I got some cramps back briefly, but they've gone away since. There were a few times when I went back to Planned Parenthood and I was worried about it, and I almost got it taken out a few times, but they kept telling me it was normal, and so I stuck it out. But when I had the cramps come back at the beginning of this year, I was almost honestly worried enough that I was going to take it out because I was worried about it possibly making me infertile. But I kept it, and now that I have none of the side effects, it's fantastic. I dread having to replace this thing because it was just so painful when I got it in. But I want a long-lasting birth control, and I think the second longest lasting one is the one that goes in your arm, and I really don't want that one. I want to point out that this person is considered a success story. She's very happy with her method, yet even her story has physiological and relationship influencers. Her experiences will definitely inform her future method decisions. Accepting that the contraceptive journey is the lived reality of most, if not all, contraceptive users has several implications. For me, one of the largest is the crucial importance of expanded method choice. We must do better in providing people with all options possible. As individuals move through this process, their understanding of what they want expands, but the number of methods that they have available to them contracts. It does not work to prioritize one method over another. We must prioritize making all methods available and ensuring folks can access them. As a hop onto this take home, I want to underscore the critical importance of developing new methods, particularly non-hormonal and male methods. We need every possible option on the table. A second is the recognition that clinicians and public health providers have a limited but really important role to play in women's contraceptive journeys. I'd like to borrow from Dan Savage and coin this recommendation, the contraceptive campsite rule, to leave clients better than when you found them, because your role in their contraceptive initiation, use, and cessation matters. Not just in the context of their current experience, but in the context of the future methods that they will likely try. By accepting that the client is making complex decisions based on a variety of dynamic factors, I think it's easier to identify and understand our limited support role in their journey. And finally, I want to note that if we believe in the contraceptive journey and that it's the reality of use, we must acknowledge that the current tortuous route of navigating contraception is an immense aggregate burden over the reproductive life course. We have to acknowledge the barriers that people navigate are ongoing. And as such, we need to consider sustainable approaches to improving the ease of initiation, use, and discontinuation. So thank you very much for all of your time, and happy to hopefully see some of you or discuss this later.
Thank you so much, Dr. Simmons. That was really wonderful and also really touching to tell these stories about women. You know, everybody has a story and everybody has a journey, but it was really touching the way you did that. It was wonderful. And thank you for providing the link to the slides in the chat if anybody wants to see those. Any questions for Dr. Simmons? So I have one. In Utah, this is a real challenge, isn't it? That we have, we want to try to give people the best information. Sometimes we're hoping they're going to get it at home. What do you see as the way we could in our state move forward in helping young people get a better handle on sex education, on contraceptive education? Is there a way forward that you could see that could be culturally sensitive and appropriate for all of us in Utah, in our state? You're muted.
Thank you for that question. I think that, there's a lot in that with respect to sex education and contraceptive access. I think that one of the best things that we could do in our state to really improve people's abilities to use different methods over time and start and stop methods would be to have a Medicaid family planning waiver. We have so many people who fall in the coverage gap within our state and who don't have the opportunity to afford methods that are more expensive, like IUDs and implants, or even try them to see if they like them. So I think that the biggest help that we could do would be to have some policy change that actually makes these methods affordable for people who are in low income situations. And if we could do that, I think that would be a huge hurdle to overcome. And it's been, we had a family planning Medicaid waiver that passed and then was subsumed into the Medicaid expansion that happened. And I think if we could get a Medicaid family planning waiver on its own as a standalone piece of legislation, that would really go a long way to really supporting folks' access over time.
That's a really good idea. I'm hoping that you guys are all working with that in the family planning group and with Planned Parenthood, et cetera. So
yeah, Dr. Sanders is working really hard on that.
Okay, yeah, it's there was somebody from Robert dude, for conservative legislator, 5 years of OCP equal ovarian or uterine and ovarian cancer prevention pills. Mirena is a uterine cancer prevention device.
Yeah, the removal of sex from this conversation and acknowledging that a lot of people need and use contraception for reasons that are not around pregnancy prevention is an area that we're starting to pursue a little bit more fervently, because they are medications that people need for their reproductive health. So I think that's a really great point. And also Katherine's point to saying period management medications is another way of reframing this so that people can see the overall value in having this expansion. So I love those.
Great. Well, we look forward to some updates next year at this meeting. Next, it's my pleasure to introduce Dr. Charles Hoy-Ellis. He's an assistant professor in social work, and he does scholarships on mental health and LGBTQ in middle-aged and older individuals. And his title is, I love it, Over the Rainbow, Health Equity for Sexual and Gender Minority Older Adults. Thank you so much, Dr. Hoy-Ellis. We're thrilled to have you here.
So thank you all for being here today. My name is Charlie Hoy-Ellis. I'm assistant professor at the College of Social Work, and I particularly want to thank the University of Utah Center of Excellence in Women's Health. So I'm going to start out my talk today on Over the Rainbow, Health Disparities and Health Equity Among Sexual and Gender Minority Older Adults. I'm going to really briefly talk about language, step into health disparities, which will signpost a path towards health equity and what we can do to move forward in terms of promoting health equity for sexual and gender minority older adults, which the National Institutes of Health has officially designated as a health disparate population for the purposes of research. And I've been using this, although I used to use lesbian, gay, bisexual, transgender, but then there's the whole who's being included, who's being excluded through language. So SGM, sexual and gender minorities, includes LGBT. It also includes two-spirit people, queer people, intersex people. It also encompasses those with same-sex or gender attractions or behaviors who may still identify as heterosexual. So the American population is aging rapidly. 130 million currently age 50 and older, 4 million of whom identify as sexual and gender minorities. Numbers is estimated to nearly double within the next 9 years. So this is an example of a health disparity that sexual and gender minorities experience. So we compared population-based data. So we compared lesbian, gay, bisexual adults age 50 and older to their heterosexual counterparts. And as you can see here, 1 in 4 LGBT older adults experiences significantly clinically significant depressive symptomatology and or psychological distress, compared to about 7% of heterosexuals. Other health disparities include cardiovascular disease, high blood pressure, diabetes, disability, obesity, asthma, subjective cognitive decline, and many others more. We are doing research. So often when I'm doing a talk like this or going to a program or agency to do a training about culturally sensitive practice with LGBTQ or sexual or gender minority older adults, I often hear, well, we treat everyone equally. And, that's great if the playing field was equal. But as you can see in this graphic here, the playing field is not equal for everyone. Some people experience barriers to health equity. So health equity is this idea that everyone should be able to enjoy the best health possible. And so in order to do that, there needs to be equitable access to healthcare services, social services, things like that. And so a health equity perspective says we need to identify what those barriers are that are preventing people from achieving health equity or the best possible health that they can achieve. So these health disparities, these differences in outcomes at the population level, when we talk about health, we're typically only talking about the tip of the services, health services. So we're not really talking about the values, assumptions, beliefs, cultural aspects, social aspects, gendered aspects of these upstream determinants of downstream healthcare outcomes. So most of us experience what are understood to be general stressors. So these are things like unexpected ending of a close relationship, unexpected job loss, serious illness, things that most of us will experience at some point in our lives. But sexual and gender minorities experience additional minority stressors on top of these general stressors. So there's actual or anticipated discrimination and victimization. This can be acute, like experiencing a hate crime, or it can be chronic condition. So living in an environment that is not necessarily supportive or affirming sexual and gender minority identities and orientations. More internal to the person is this fear of rejection. So if my sexual or gender identity becomes known, people, especially important people, so friends, family members, loved ones, employers, things like that, may reject me. And so in an effort to escape that potential rejection or discrimination, sexual and gender minorities may camouflage themselves. This historically has been known as hiding in the closet or concealing one's sexual orientation or gender identity. And then there's internalized stigma. So this idea that we've all internalized the dominant culture's prevailing attitudes, stereotypes, and beliefs about marginalized social groups such as sexual and gender minorities. And then that stigma is targeted towards the self. So these all are chronic stressors. So you've got your general stressors and then your minority stressors that overactivate and chronically overactivate the HPA axis, which ultimately leads to accumulated wear and tear on the body, what's known as allostatic road. So you've probably seen an actual or a picture of an old dilapidated fence that's been out in the pasture for decades and decades being exposed to the weather. So it's gray and falling apart and everything. So that same thing happens to our bodies as a result of this chronic overactivation of the stress response system. So my research has shown, and others' research has shown, that long-term concealment of one's sexual or gender identity significantly increases the risk for psychological distress, as does internalized heterosexism and comorbid chronic health conditions. And even low levels of psychological distress significantly increase the risk for premature morbidity and mortality. So we took Myers Minority Stress Model, we embedded it within a life course, sociological life course framework and a developmental psychology lifespan framework. So typically when we are talking about health, so there's physical health, mental health, so these are some key health indicators. And then when we're assessing people for healthcare or healthcare access or healthcare conditions, we typically look at these adverse and health promoting pathways. So what's your diet like? Do you exercise? Do you smoke? Do you drink excessively? Things like that. We also look at social and community supports and structures. You'll see here the phrase identity management. This is a fancy term for this idea of camouflaging or concealing one's sexual or gender identity. And I also talked just a moment ago about higher cortisol levels and allostatic load. But we typically don't think about our people's intersectional identities, and that what happens earlier in life continues to reverberate throughout the life course. And we typically don't look at these multi-level contexts, these structural, institutional, and individual levels of social exclusion, marginalization, stigma, microaggressions, discrimination, things like that. So all of these things are working in tandem to get us to these health outcomes. So we can intervene anywhere here in the way. I'm going to suggest one small place we can intervene that's going to have lots of positive long-term consequences is here at the structural and individual level of discrimination and victimization. And so jumping back for just a moment to that life course context. So what happens earlier in life continues to impact us throughout our lives. So today's midlife and older adults were born in an era, so until 1973, homosexuality was by definition, American Psychiatric Association's definition, a sociopathic personality disturbance. At the same time, sodomy or any sexual activity not specifically designed for procreation was illegal in all 50 states. In 1963, Illinois became the first state to decriminalize sodomy. It wasn't until 2003 that the US Supreme Court struck down the remaining sodomy laws in the United States, at which time same-sex sexual behavior was still a felony in 17 different states. And being arrested on such charges, it's not just the arrest, but your name, your phone number, everything's printed in the newspaper. So people would actually lose their jobs, their families, and have to move to a new place to live. So many midlife and older adults will hide who they are, conceal who they are, camouflage their sexual orientation in order to avoid harassment, discrimination, isolation in healthcare settings. And this has actually been documented that this actually does happen. But as I pointed out, going back into the closet to safely access services further increases mental and poor mental and physical health outcomes. So we know that 1 in 5 sexual and gender minority midlife and older adults are not out to their healthcare providers. And so this can result in suboptimal or poor healthcare, in addition to those long-term consequences of concealing one's identity. I'm not going to show these 2 movie clips because whenever I show a movie clip on Zoom, it kind of gets wonky. But if you ever get the chance to see Gen Silent, it's a documentary that follows the lives of 6 LGBT older adults in the greater Boston area as they navigate healthcare and social systems. And then Southern Comfort is a documentary that follows the last year of this man's life. The reason it's the last year of his life is he was seeking treatment for a diagnosis of ovarian cancer, and 20 different providers refused to see him because they were concerned about how other people in the waiting room might feel uncomfortable. By the time he found a physician that would treat him, that was already too late. The ovarian cancer was inoperable. So what can we do to move health equity forward for sexual and gender minority midlife and older adults? So typically, when we think about intervention and prevention, what about educating ourselves? So what does our practice setting look like? What do we understand about the social determinants of health for the people who are coming to us seeking services? Does your practice setting engage in community events? So, for example, the Jewish Family Services collaborating with Utah Pride Center because they recognize, hey, we have midlife and older Jewish sexual and gender minorities. Maybe we should think about serving them also. Letters to the editor can be powerful. Contacting representatives. We really need to get the Older Americans Act adjusted so that sexual and gender minority older adults are formally designated most vulnerable population, so we can direct more funding towards their health and social care needs, as well as the Equality Act. It's still legal to fire someone or deny services, healthcare services, public accommodations, things like that, based on sexual or gender identity in half the states. So here in Utah, we have SAGE Utah, Service and Advocacy for LGBTQ older adults. I'm not going to click on the link here, but here is a link. Just go to utahpridecenter.org and click on Senior Programs, and you'll be able to see the amazing, amazing work that SAGE provides for our midlife and older sexual and gender minority or LGBTQ population here in Utah. So coming back full circle, when I walk into your place of practice, your healthcare provision, your social services provision, do I see myself represented? Do I see anything like this anywhere in your waiting area, in your lobby, whatever, that tells me that you recognize that sexual and gender minority people are part of the population that you serve? And by saying that we treat everyone the same, you're actually continuing to marginalize LGBTQ older adults. But if you recognize that pride comes in all ages, that LGBTQ people and their caregivers also experience dementia-related issues. If I see a magazine on the coffee table or the end table about understanding issues facing LGBTQ older adults, the message I'm getting is that I'm recognized, I am seen, and people know that I may have specific needs. So if I see myself represented, I am more likely to disclose my sexual orientation or gender identity, which is going to help my mental health, but it's also going to support the provider in providing the best services possible. So I want to thank you all very much for allowing me this time today. And I believe that we now have a short Q&A period.
Thank you so much, Dr. Hoy-Ellis. That was really inspiring to us all. We're open for questions. You can put them in the chat if you want. Otherwise, I'm going to ask you, how do you get that little poster to put in our waiting rooms to say, yeah, we're the University of Utah we are trying to be thoughtful about equity and inclusion in our clinics as well as in our employment. How do we get that little poster? That's a good one.
Well, you can actually contact the organization. So I know that the Alzheimer's Association here in Salt Lake City. Some organizations, they have like I don't know what you call it, some kind of like display stand or something that has lots of different pamphlets about different health issues and things like that. And so they actually have little pamphlets specific to LGBTQ midlife and older adults and Alzheimer's caregivers for midlife and older adults. So you can just ask them. You can also contact national organizations that are always willing to share their advertising and media. And I can't really tell you, just it seems like such a small thing, but it's actually such a big thing. And, you know, thinking back to that life course perspective, so I shared about sociopathic personality disturbance. Actually, still today, we're seeing the same trajectory with gender identity and gender dysphoria. The very medical institutions that used to really do bad things to good people are now asking that we trust them. And, you know, I think that's legitimate, but you have to show that you're working towards trusting. So just like you asked, where can I get a poster or a sticker or something like that? It's a small thing, but it can make a huge world of difference.
I think you're right on that. Any other questions from our audience?
This is Karen Schliep. I have one question. I have a colleague who does a lot of work in the veteran population on sex and gender minorities and subsequent health outcomes. And one thing that I was really interested in some of her research is the number of times, and of course she uses a lot of her research in this big database of EHR records, and the number of times it takes an individual to go see their provider before their sex or gender minority status appears in the record. And I'm just wondering if, which is very important, I think, in this idea of what you said in the end, that it can help address care issues. Do you see that improving in Utah, or do you see that that it really does that indication of status just goes without ever being known by the physician or care provider, or are we getting better?
I'd like to say we're getting better. That's a great question. I'd like to say we're getting better. I think here and there people are getting better overwhelmingly. So I also, so one of my other hats, I teach in the MSW program, and I teach diversity reflexive social work practice classes. And one of the things that I struggle to convey to students who are actually more open to it is that when you go in for whatever healthcare or social services, there are standard demographic questions that are asked. So race, ethnicity, sex, gender, things like that. And sexual orientation and gender identity should be asked of everyone, but many people still don't see that it's important, that it's anything that really needs to be known, even though the American Medical Association has officially stated that patients' failure to disclose and physicians' failure to ask results in suboptimal or poor or even negative healthcare. I think doing that could eventually go a long way. So I've been out since I was 15, so the majority of my life. And I'm good with it, everything. I no longer take the pill to turn me straight or anything. But there's one clinic at the University of Utah Healthcare. I've been there on 2 different occasions with 2 different providers. And although no one asked me my sexual orientation or gender identity, when I just randomly in the conversation brought up my husband, I could literally see these people clench. One of them literally moved to the other side of the room, so doctors sit on those little wheeled stools, and just immediately went to the other side of the exam room. And so I think the implicit bias, none of us, especially in healthcare provision, want to believe or think that we're biased. But if we have a brain, we're biased. It's just the way we're wired neurologically.
Yep.
And so I think that normalizing, making questions about sexual orientation and gender identity just part of the standard battery of questions helps normalize that, and can help people recognize when their implicit biases are starting to pop up.
Thank you for that. Robert Dude, did you have your hand up? Did you want to say something?
Oh yeah, I just had a good question. Thanks, it was a great talk. I'm a GYN cancer provider, and we as a group had just kind of made a recent decision. We switched over from kind of women's health to then being more inclusive to just being very specific, which is breast and gynecologic cancer center. I was just wondering, Human Rights Campaign has a few things, but not necessarily kind of gold standard for best practice. Can you think of kind of, is there a kind of best practices where we could really be labeling the care that we're providing that is both kind of less clunky than like persons with a uterus or persons with ovaries, but still being very inclusive in both clinical care, but then also kind of the research world and fundraising world where we're kind of trying to figure stuff out right now too?
That's a great question. Ironically, myself and some of my colleagues at the University of Washington, so I continue to collaborate with the National Health, Aging, Sexuality, and Gender Study. And we currently have a manuscript under review. So we looked at behavioral risk factor surveillance system data. So it's actually just been the last 2 or 3 years that these large population-based data sets have been asking questions about gender identity, a little bit longer for sexual orientation. This particular manuscript, we're actually looking at comparing transgender non-binary older adults' utilization of preventive healthcare services to cisgender older adults' use of preventive healthcare services. And so those that are actually recommended beginning at the age of 50. And what we found, and actually not surprising, is that roughly about 40% of transgender, gender nonconforming midlife and older adults access recommended preventative screenings compared to 80 to 90% of cisgender. But your question brings up a really interesting thing, which goes back to why I'm moving more towards sexual and gender minorities as opposed to LGBTQ. So just looking at the recommendations, for example, for breast cancer screenings for transgender women, so those who were assigned male at birth, that have engaged in affirming care to make their bodies look more like a woman's body and function more like a woman's body. But transgender men who may have had breast reduction surgery may still be at risk. So right now, what we're showing is that A, the guidelines aren't being met, and B, there's not really any good guidelines for sexual and gender minority older adults, especially when it comes to uh, uh, challenges like you were pointing out. So I may have had a uterus when I was born, but I don't now. And at the same time, so going back to that, 1 in 5 sexual and gender minority older adults is not out to their healthcare provider. So if I'm a transgender woman and my healthcare provider doesn't know that I'm a transgender woman, they're not going to know to encourage me to get a prostate exam after the age of 50. So we just started establishing these disparities in accessing preventive healthcare services. And so our next step is to partner with other healthcare providers. It's like the Center of Excellence for Transgender Health, different places like that, and develop preventive care guidelines specific to sexual and gender minority older adults. So that's in the works, but that's the next step that we're embarking on.
Thank you so much, Dr. Hoy-Ellis. We really appreciate your talk and the great discussion. Our next speaker is Dr. Karen Schliep, who spoke to us earlier about the journal, but she is an assistant professor in public health and studies epidemiology. And I'm very excited about this talk. She's doing a sex and gender differences in the risk of Alzheimer's disease and other related dementias. So thank you, Dr. Schliep.
Hi, my name is Karen Schliep, and I'm excited about sharing some research on sex and gender differences in the risk of Alzheimer's disease and related dementia. So as many of you know, dementia is a huge public health problem, both in the United States and worldwide, with over 6 million Americans living with Alzheimer's, and this number is expected to at least double by 2060. So as prevalence increases, largely due to us all living longer, we have actually, and good news, had a slight decrease in incidence. This is findings from Denmark, but have been replicated in studies in the United States, such as in the Framingham, that followed 2 million individuals. And we see from 1996 to 2003, roughly a 9% increase in risk, followed by a change in direction in 2003 to the present of a 2% decrease annually. What is this due to? Largely increased opportunities of education for women over the last century, as well as heart health improvements such as diet, lifestyle, and pharmacotherapy. So are there sex differences? Indeed. Among those with dementia, 2/3 are women compared to 1/3 being men. How about in incidence or risk? Again, twofold higher risk of lifetime risk of dementia for women compared to men, whether you look at age 45 or 65 lifetime risk. So what are the reasons for this higher risk? Well, studies are still being done. It's not entirely clear, but for the most part, this is largely due to women living longer than men, and age is, as we know, the greatest risk factor for dementia. So as you see on the graph on the right, whether you adjust for age or in this case stratified by age, you basically end up with nearly equivalent risk for dementia at any given age between men and women. One of the most important things, though, I hope to take away from this talk is that even if women and men have the same incidence or risk of Alzheimer's disease and related dementia at any given age, the mechanisms, pathways, and risk factors can still differ. And this is very important implications for public health interventions or even for clinicians working with their aging populations and thinking of precision medicine and how you maybe want to target certain risk factors for your patients in men versus women. So these differences between men and women may be due to biology, such as chromosomal or hormonal differences, also known as sex differences, or differences in environmental, social, and cultural influences on men and women, also known as gender differences, or most likely a combination of these two. One quick note on just making sure we're all on the same page in regards to effect modification. When we think about death, the strength of the association between any risk factor and an outcome, in our case, Alzheimer's disease and dementia, differ by some third factor, in our case, sex. That is when we have, in a classic sense, effect modification. And you can't just adjust for sex and gender as a confounder if we wish to tease apart this potential effect modification. One important note that every student in Epi 101 learns is that a factor can be a confounder, an effect modifier, or both, and I'll show examples in this talk of that. So let's now kind of, with this idea of effect modification and confounding, kind of think about reasons for sex and gender differences when it comes to dementia. In the first case, a classic effect modifier, we can have risk factors with the same frequency but have a stronger effect in one sex. This has been shown with the ApoE genotype, which is a risk factor for late onset Alzheimer's disease. It's been found that women that are either heterozygous or homozygous for the ApoE4 allele have a greater risk of dementia as compared to men with the same genotype. In the second scenario, we can have risk factors that have the same effect but differ by frequency. So it's just a larger contribution to how a man or a woman might develop dementia. In this case, education and smoking. Classically, men had higher opportunities for education. Thankfully, this has changed in the last century. And smoking rates, so one being a protective factor and one being a risk factor, but they were just higher in men than in women. Thirdly, risk factors can differ by sex in frequency and effects. And this is that idea that a factor could be both a confounder and effect modifier. And I will go into some detail about this with traumatic brain injury later in the slides. And then finally, there are some risk factors that are truly restricted to one sex. So we think of pregnancy in women or therapies for prostate cancer in men. So let's dial into some of these sex differences. We know that women have twice the risk of depression as men, and this is an important link to cognition as mood and memory map to the same brain regions. Prior studies show at least a 70% increased risk of AD dementia for those with depression in midlife. So we know that there's a difference in frequency. Women are more likely to have depression than men. But what about effect modification? Is there a difference in the strength of an association? Well, this was a really good recent study that just came out in 2021, looking at depression, both recent depression, that active in the last 2 years, or depression more than 2 years ago. And here you find that actually only recent history of depression was associated with higher risk of Alzheimer's disease. And this impact was stronger in females than men. Granted, it was not statistically significantly different, as you see 2.27 being within the confidence interval of the hazard ratio for men. But as we all know in EPI, we are not focusing on statistical significance now. We're focusing on the magnitude of effects and the variability around those effects, and turning to our clinicians and public health research experts to help inform as to whether those are meaningful differences. So turning to our own findings, we looked at some of these sex differences between men and women in the BRFSS survey from 2015 to 2018. And here we found, similar to what I was showing earlier in regards to incidence, that we have, well, this is a cross-sectional study, so even looking at prevalence, we actually have found that there's almost nearly identical prevalence of subjective cognitive decline between men and women after you take into account age and race ethnicity at about 11%. What about risk factors, sex difference risk factors? Well, in depression, this is an important risk for subjective cognitive decline. It's one of our strongest findings of modifiable effects, with over a threefold increased prevalence ratio for women versus men. However, it was nearly identical in terms of a 3.2, so no real differences in the risk. However, if you look at prevalence, you almost find this doubling of prevalence of depression in women than men, and meaning that then it would contribute more to the population triple fraction for explaining the cause of dementia in women versus men. When we also looked at this in the VA data, this was a fun data set to look at just because I've never had a sample that I start with over 20 million individuals. Granted, they boiled down after we restricted to those only over age 45 as of January 1st, 2000. They had to have some kind of inpatient, outpatient visit in the corporate data warehouse. And we excluded all prevalent dementia because we really wanted to look at modifiable factors prior to an incident dementia diagnosis. But here we find, as again, we adjust for age and race and some other factors, and we find nearly identical incidence of dementia at 12%. In terms of risk factors, here's where we actually found a slightly higher risk of the impact of depression on dementia among men versus women. We have fairly precise confidence intervals due to the large sample size. They're not overlapping. We had significant interaction. But again, it would be turning to clinicians and public health professionals as to knowing whether this is a meaningful difference. But one thing I'd like to point out is the prevalence for both women and men among the veterans for depression is high. So regardless about this impact, you would actually see this as a really important contribution for both women and men in terms of explaining potentially dementia later on. So our next steps, at least in the Vinci data, is to replicate the Kim et al. Study, in which you really want to dial in and say, is it recent depression that is linked with increased risk of dementia? And if this is the case, then we might reconsider how important depression is. Granted, it's hugely important for many other reasons besides its link with dementia, but we really want to understand, is it a potential consequence versus cause? And then does this difference, this greater impact for men versus women still hold when we look at recent depression? And then some gender differences. We find women have traditionally had less opportunities for education. Low education is a strong risk factor for dementia. There's research, as I mentioned, to support decline in dementia incidence since 2003 due to women's increased opportunities over the last century. And then is it just a frequency issue or not? Well, there's been several European studies that actually show that education might be an effect modifier in that the risk of dementia with lower education is stronger in women than men. How about with social isolation? Well, this is something that seems to be more of an issue for men than women. Men who have never been married or widowed are at greater risk of dementia than women. Why? Well, this is thought to women being responsible for healthcare of others, and it sometimes is at the expense of their own health. And there potentially are other reasons that could explain this as well. And finally, traumatic brain injury. We know that men have higher prevalence. Think of football, think of military. But do they also have a higher risk for dementia compared to women? So turning to our findings for education, social isolation, and traumatic brain injury in our data sets, we found that actually limited education is not a real important risk factor for subjective cognitive decline. And the prevalence of limited education was actually fairly low among this national representative population. In fact, limited education was slightly higher in men than in women. But again, this is a fairly minimal risk factor, even though it is above 1 and of concern, but the prevalence is fairly low. That in comparison to social isolation, which is one of our greatest, highest population attributable fractions for subjective cognitive decline, given its high risk and high prevalence. And this is important then to look at for both men and women. So we did find that men had slightly higher risk of subjective cognitive decline with social isolation compared to women, but actually women had the higher prevalence. So this, and over 50%. So regardless, it is one of those really important factors that you'd want to consider, from a public health standpoint for addressing if you're trying to think of modifiable factors and decreasing dementia. So what about veterans and TBI? Well, this is an interesting that we also found this to have the highest risk for an incident dementia diagnosis, particularly among men, having a nearly 4-fold increased risk of dementia with TBI compared to a 3-fold increased risk for women, but still high for both men and women. Interesting enough, the prevalence is fairly low, but it was double in women than men just within this veteran population. So even though the prevalence is low, given that it is a high risk factor, it is something that clinicians and public health researchers would want to pay attention to within this population. So then finally turning to some sex-specific risk factors, as I mentioned, pregnancy and menopause are two women kind of exclusive events that women experience, whereas potentially prostate cancer therapy would be something exclusively men could experience. Prior research is looking at hypertensive disorders of pregnancy linked to brain atrophy and cognitive decline, whereas one missing link of that is whether it's actually related to a dementia diagnosis, and more importantly, what type of dementia diagnosis. And certainly another area of research that's being done is looking at early menopause linked with increased risk of dementia, as well as androgen deprivation therapy linked to cognitive decline and risk of dementia among men with prostate cancer. So turning to our own findings, we have looked at hypertensive disorders of pregnancy and its risk with dementia, and actually found that the big driver for the increased risk is with vascular dementia rather than Alzheimer's disease. And this helps to dial into what type of dementia that we would want to be on the lookout for among women with a prior history of hypertensive disorders of pregnancy. We're turning finally to research looking at mediating factors for this sex-specific risk factor. Does hypertension, midlife obesity, midlife depression alter the relationship between a hypertensive disorder of pregnancy history and future dementia, particularly vascular dementia? And with that, I'd like to thank my collaborators and mentors for my KO1 funded by NIA, as well as my collaborators from Vinci.
Thank you so much, Dr. Schliep. That was just excellent. And I know everybody is interested in dementia as we all get older. I was really surprised by the prevalence of head trauma in the veteran population, the prevalence that you found. Do you think, how do you explain that one?
So that, like the higher prevalence in women than men?
Yeah.
Yeah. So, it's, there might be kind of gender differences in, I wish I knew more about veterans and combat, but, part of me thinks of active military members and the training. It's an interesting question. I can't answer it, but it is, it's one of those in which, it's double the risk for women. So it's something that needs to be looked at.
Yep. Thank you. Thank you. We're going to move on to Dr. Claudia Geist. And we are thrilled to have Dr. Claudia Geist with us. She's the Associate Dean for Research in the School of Cultural and Social Transformation here at the University of Utah. She's an associate professor in gender studies. She's an adjunct associate professor in OB-GYN. And her quantitative research is what she usually does, her talk today is not empirical, and she apologizes in advance for getting a tad preachy. I'm anxious to hear the sermon on this one. So Dr. Geist, thank you so much for being here with us. We really appreciate your coming.
Hello. My name is Claudia Geist. I use she, her pronouns, and I'm a faculty member in the Department of Sociology in the Division of Gender Studies. I also have a courtesy affiliation with the Division of Family Planning. My research focus is on gender inequality, broadly defined. I study topics like the link between pregnancy intentions and economic constraints, contraceptive use patterns and comparative perspective, the domestic division of labor, alongside more abstract topics such as how people conceptualize sex, gender, sexuality, and family. There's a good chance that you will be mildly exasperated at the end of my talk. but maybe I'll also provide some context that energizes you in the work you already do. So instead of giving one neat 15-minute talk with pretty slides, you will just get me as a talking head today. And I'll give you, in a sense, 2 mini talks that reflect both my pragmatic side, likes to deliver a talk that actually matches the title I gave myself, and sort of the rebellious side of me, that things maybe we need to do some more fundamental rethinking of the terms of gender. So for the first part of my talk, I want to make the argument that we need more and better policies that center reproductive labor. And in the second part, if you're still with me, I'll make a more perhaps radical or fundamental argument about the necessity to change the way we think about gender to really address systematic inequalities and systematic discrepancies in health. But before I go into the abstract policy speculations, let me give you just a nugget from research that I did with a colleague at the University of Wyoming, Dr. Jenny Tabler, using time use data. Our study of married heterosexual couples 60 years or older found that even when neither person is working, women still do more housework. Time spent on chores for both older women and men is shaped by their health. But the amount of time men spend on housework is less impacted by their health, either their own health or that of their wives. That's partly because husbands' housework involvement is shaped by gender divisions in the first place, and say a healthcare provider's well-meaning recommendation to a female patient that she needs to cut back domestic chores, say in response to health problems, may not be heeded because of entrenched arrangements. So, to improve population health in general, women's health specifically, and reduce inequality, which also includes the deep racial injustices that persist, we perhaps need to focus first on policies related to reproductive labor. This includes childcare and housework, of course, but also caregiving more generally. And I'll also include the work, effort, and sacrifice related to pregnancy and birth. Universal health care that is not tied to employment status, family status, or marital status, that is, say, insurance through spouses or one's own job, can go a long way. Access to methods, devices, and strategies to prevent pregnancies for the time being or forever need to be a key component. It also includes the right and practical access, both financially and logistically, to abortion services, as well as fertility treatments to help achieve desired pregnancies if people want it. Giving birth should not come with a sticker shock. And it should come with robust postpartum support, not only for the child, but also for the person who has given birth and their needs for the whole person. To achieve this, the way we pay and provide healthcare likely has to change. One big reason why not tying healthcare to employment status would be important is that this will allow people to make choices about the types of jobs that they have without worrying about being cut off from healthcare. It bears repeating that one of the reasons why labor force participation and caregiving patterns are so deeply gendered is that in heterosexual couples, women are still likely to earn less than their spouses, which means that if the decision has to be made that one person has to cut back on working, say during an epidemic or a pandemic, a child suddenly needs to do distance learning and cannot be left home alone, or other caretaking needs arise, it's women who cut back, and then maybe relying on spouses' health insurance and financial support. And I get the idea that treating families as a unit, providing family coverage, it's a popular idea. But it also imbues power in the person who holds the policy and sees people only in the context of their relationships rather than as individuals. But decoupling healthcare access from paid employment is not the only way to lessen the gendered impact of reproductive labor. Access to early childhood care that does not have to be provided by parents and generous paid parental leave benefits are another part of the puzzle, to give people a choice to find the care arrangement that meets their needs best. As long as there's no universal access to paid parental leave, nor free or heavily subsidized early childhood care, it's really not surprising that those who may have just given birth are more likely to cut back their labor market engagement, will suffer lifetime earnings losses, and will, for the life of the child, be seen as primary parent. Remember that research finding I mentioned earlier? Patterns of unequal division of labor and care, once established, are likely to persist throughout the life course. The third piece, or perhaps an extension of the second proposal I'm pushing on you here, revolves around work-life integration more broadly, beyond postpartum and early childhood care. And the mismatch between school days and lack of free or affordable care during summer months puts especially mothers' labor force attachment, their economic independence, and in turn, their longer-term health and economic well-being at risk. We have even less support for people who have significant elder care responsibilities. Don't get me wrong. Individual employers in some states and some local programs have made great strides in helping make things better. But we also know that often those who need these policies and programs the most are not eligible. So one quick takeaway could be that I argue for universal healthcare access, policies that help people with care responsibilities retain their jobs, as paid employment is in the absence of universal basic income. That's pretty much the only way to ensure the kind of financial stability that reduces the risk for poor mental health and unhealthy levels of stress, and the ability to leave unhealthy relationships. These policies would disproportionately affect women and women's health. So while I want to reiterate that the reproduction-related processes are at the core of much of the gender inequality we see that also spawns health challenges women, it's not enough. So for the last few minutes of my talk, I want to make the argument that we have to rethink how we deal with gender, how we think about gender, to make things better. And rather than start at the reproduction angle, we need to fundamentally just change how we socialize children in early childhood. The reason why this is not just sort of an academic exercise is that you as healthcare provider and gender disparity and health scholars may face the vexing problem that in human populations, we cannot really separate the parts of health outcomes that are linked to biological markers of sex and what part are socialized gender differences. Biologist and gender studies researchers Anne Foster Sterling has highlighted how there are many different layers of biological sex, but research has shown that both pre-birth and immediately postpartum, we treat children in gendered ways. So we treat those who we assign male at birth and those who we assign female at birth in different ways. We affirm behaviors differently, reward different behaviors as early as several months old. And so I want to tell you that we cannot observe sex differences in human populations as long as we treat developing humans in gendered ways before they even have a chance to develop their own gender identity. Even worse, we often deny children, adolescents, and young adults the affirmation of their gender identity if it does not align with the sex assigned at birth. And we constrain gender expression throughout the life course. Research has shown that rigid gender norms are detrimental. The Global Early Adolescent Study has shown that unequal gender norms develop early in childhood and intensify in early adolescence. The societal expectations of boys and girls differ, and so do their own gender attitudes. Peers, parents, the media, all are powerful influencers of shaping gender norms and attitudes. both conformity to gender stereotypes has negative health outcomes. Think body image challenges, focus on hypermuscularity, peer pressure to drink, but also non-conformity to gender stereotypes also has lasting effects, as being non-conforming in adolescence results in greater risk for stress, poor mental health, and victimization. So this is where the really frustrating part comes in. I'm telling you that gender norms, the gender binary, and the assumptions of near universal heterosexuality and cisgender identities harms everyone, even those who are extremely comfortable in the heterosexual and cisgender identities. But these concepts constrain people, force them to be who they may not be, and they channel them in unhealthy behaviors and limit who they can be. So the gender studies professor in me would like to simply, say, let's break free of all these boxes and reinvent something that is better and less constraining. However, in everyday practice, what we need to try to shape policies, treatment plans, research approaches in a way that does not actively reinforce the heterosexist cisgender binary, or at the very least, does not further marginalize those who are outside of these very narrowly constrained categories. It is difficult to empower women and affirm those with marginalized gender identities, as sometimes the idea of sort of essentialist feminism may come hand in hand with the rejection of trans identities. But I tell you, it does not have to be that way. The rejection of narrow gender norms benefits everyone. I appreciate this time with you. You're probably ready for a break. I will try to make available a brief resource list so you can read more what I talked about, and I look forward to your question in the Q&A.
Thank you so much, Dr. Geis. That was really terrific. I don't think you challenged us, but not too much. And I would just like to start out a question saying, you're challenging us to change this, but how do we do this when it's absolutely been ingrained in our society for so long? I mean, I think the fact that we're, at least in tune with it, allows us to make some changes. But give us some ideas of how we might do this.
Well, I think the easy sort of low-hanging everyday practice fruit is sort of a follow-up to some of the affirming healthcare talk that we saw earlier, is to just stop making assumptions. And so a few years ago, I heard a talk about, sort of women's health problems and spinal issues. And it was like, oh, all these high heels women always wear. And essentially, I was like bouncing in the background. So it's like, well, not all women, like gender expression really varies. And to just be more precise, especially for healthcare providers. And I realized that, sometimes it's really hard to talk about like people and like always go with the organ inventory, but to just sometimes like stop and pause and think about, assumptions we make in interactions with children. It's really hard to fall into sort of like stereotypical gender things and behaviors that, really don't benefit anybody. So like the small changes can be to just like make fewer assumptions and be sort of like openly affirming. The bigger ones is to just try and maybe push back and remind people that, not all children are biological. Not everybody is married, not, like all these kinds of like sort of structural
the question, what kind of structural assumptions are built in some policies? And then depending on your position to gently push back or be grumpy about it. That is up to the comfort level of everybody, of course.
Great. That's a great answer. Thank you. Any other questions from our audience? If you have questions, you can always send Dr. Geist an email too through the university system. But I love that you could be here with us and talk about this, because I think, we're going to continue to encourage you to be part of our conference in the future, because if we can take care of some of these social constructs, I think some of the health consequences will also follow, as what we found out from Dr. Hoy-Ellis too.
Yeah. Well, thank you for having me, and thank you for your patience. I know sometimes it's easier to talk about it, and the everyday implementation is difficult, but I believe in all of you. Thank you.
Yeah. And now I'm going to turn it over to Dr. Michael Varner, who is going to introduce our next group of speakers.
Thank you, Kathleen. So I'm Mike Varner. I'm a professor in the OBGYN department, and I'm a co-director of the Center of Excellence in Women's Health here. I'm also the research director for the Utah WRHR K-12, which is an institutional training grant for junior faculty interested in research careers. You know, one would think that after however many years of medical school residency and fellowship, that people might be adequately prepared for a research career, and it turns out that people coming up through that clinical pathway are seldom adequately prepared for a sustainable research career. The NIH has realized that, and they have a whole smorgasbord of different career development award options for junior faculty. One of them is this WRHR, WRHR, Women's Reproductive Health Research Award, which is awarded to institutions that are adequately prepared to facilitate research career development of junior faculty. We have the good fortune of having one of those 15 awards in our department. Each of them funds career development for 2 scholars at a time. And as you can see from the agenda, our 2 WRHR scholars are Nathan Blue and Rob Dude. What I'd like to do is just to briefly introduce each. We'll listen to their and watch their recorded presentations, and perhaps we can have a couple questions after each to strike while the iron is hot. Nathan is a graduate of Loma Linda University Medical School, his residency at LA County USC, and a MFM fellowship at the University of New Mexico. And we were fortunate to be able to recruit him to Utah coming up on 3 years ago now as a WRHR scholar. His research has been looking at placental somatic variation and its impact on fetal growth. I think it would be safe to say that it has been an alternating exercise in exhilaration and exasperation, and hopefully his presentation will explain that in a little more detail. So let's hear from Nathan.
Hello, my name is Nathan Blue, and I'm a assistant professor and maternal fetal medicine specialist in the Department of Obstetrics and Gynecology. I'm going to present to you on placentas and their genomes. My mentors are Aaron Quinlan and Robert Silver. Placental insufficiency is a sort of an umbrella term or a category of conditions where the placenta is dysfunctional in some way and leads to some pretty common and recognizable obstetric complications such as preeclampsia, fetal growth restriction, and in the most severe cases, stillbirth. Even when fetuses or neonates survive the early neonatal period apparently unscathed, they're still predisposed to a lifelong increased risk of cardiac disease and early death from cardiovascular events. We know that the placental genome is important for placental function because cases of aneuploidy, or where there is an extra or deleted chromosome in the fetus and the placenta, experience complications of placental insufficiency at very high rates. This is also true when the aneuploidy arises after fertilization as a post-zygotic change. And so it arises in one cell such that only the daughter cells in that cell line are affected. Complications of placental insufficiency occur at high rates even when the aneuploidy is only in the placenta and absent in the fetus, which is illustrated here. This we refer to as confined placental mosaicism, and it's more common than you might think. It occurs in 1 to 2% of clinically recognized pregnancies. And if you think of aneuploidy on the scale of the genome is a gigantic change. If that occurs 1 to 2% of the time, then it is plausible and even likely that much smaller scale changes occur with much higher frequency, such that the placenta is maybe a very mosaic organ genetically. So we set out to explore and investigate whether this type of variation occurs in placentas and whether it's important. So we had two hypotheses. The first is that somatic mutation, which is another word for that post-zygotic mutation, is common in placentas, both normal placentas and uncomplicated pregnancies. And secondly, we hypothesized that an increased burden of mutations, somatic mutations, in placentas is associated with placental insufficiency and adverse pregnancy outcomes. To test these two hypotheses, we have these two aims, which are first to explore non-pathologic genomic differences in normal placental function using whole genome sequencing, and specifically to identify mutations that are different between the placenta and the fetus, as well as within placentas. And then secondly, our second aim was to explore somatic placental mutation as potential contributor to placental insufficiency, also using whole genome sequencing. And to do this, we plan to compare the somatic mutation burden between different clinical groups that experience different outcomes, as well as to look for specific mutations or mutational patterns that predispose to placental insufficiency and stillbirth. We used data and samples from the Stillbirth Collaborative Research Network, which was a multi-site case control study that prospectively enrolled stillbirths and live births, in which we participated in. All stillbirths in this network study underwent an autopsy or postmortem examination, and all participants, including live births, underwent placental histopathology and then specimen collection of maternal and neonatal blood. Placentas were biopsied. 4 biopsies each were collected and frozen in a standardized and representative fashion. This figure is just from the instruction manual in one of the publications from that study. So we set out to characterize genetic variation between the fetus and placenta, as well as within the placenta, by analyzing maternal, fetal, and then 4 placental genomes from these 3 groups. The first group is a small group of normal, or I should say uncomplicated, healthy live births. The second group is an intermediate group of placental insufficiency, which was defined by severe fetal growth restriction from placental insufficiency, but with ending in a live birth. And then the most severe group was stillbirths associated with placental insufficiency. And then all of the samples, 6 samples from each pregnancy, were sequenced using whole genome sequencing at a depth of coverage of 30 to 60x, and variants or mutations were identified using GATK, which is an algorithm. So this is what we found, that there are a considerable number of mutations in each placenta. This is the median number of mutations in each placenta across these 3 groups, accompanied by the ranges per placenta. And this is also expressed as a rate, which is the number of variants per site on the genome that was sequenced adequately. And you can see that there are a lot of mutations within each placenta, but that there's not an obvious difference between the three groups. Now, these results are pretty heavily qualified because GATK, which is a standard algorithm that is used to identify variants, is not really designed for somatic variation. It's designed for inherited mutations. So it assumes that, just like you would think with inherited mutations, that at least, or about half of the sites for a given gene or a given site on the genome would have that variant, since you inherit it from one of your parents. So it's really not suited for somatic variation or structural variation. And so we thought it would be good to duplicate these findings using Freebase, which is an algorithm designed here, developed at the University of Utah Center for Genetic Discovery, because it's optimized specifically for low frequency somatic mutations, such as in cancer genomes. So this was our plan. What we expected to find, if you imagine with me that this is a pool or the group of mutations identified by GATK, that as we reassess the genomes with Freebase, it's akin to casting a wider net. And so it would identify additional mutations that GATK missed because of its very strict filtering and assumptions. But what we found when we ran the two separately is that they identified nearly almost exclusive groups of mutations with very little overlap. These numbers are the total number of mutations from all the placentas in our cohort. And so we had to make sense of this. Why does one tool identify a group and another tool identifies a whole other group with so little overlap? So we began reviewing the individual mutations and making judgment calls about whether they were real or whether they were artifactual, and using those to identify reasons why artifactual variants were arising, and then adding filters to the algorithms. And so progressively, we decreased the size of our call set from 18,000 and 12,000 down to about 6,000 and 3,700. But you can still see that there is relatively a small amount of overlap. And this is a reasonably high confidence call set. About this time, a paper was published in Nature from a group at Oxford describing what we had been investigating, which is that there is abundant mutation, somatic mutation within the placentas. And they even compared the degree of mutation to cancer. They used an algorithm to call variants or identify mutations called Caveman. And so given the disparity between our two algorithms, we thought, well, we'll use Caveman also and see if that gives us any insight. And so we thought that we would apply that and see how much overlap is between the three algorithms, or whether this could maybe be a tiebreaker to help us know with high confidence which variants were real. Now, this is the number of mutations identified by each algorithm within a single placental biopsy. So these are the GATK mutations, Freebase in green, and then Caveman in yellow. And you can see there is overlap, but they all identify a considerable number of mutations that the other three miss. And so this is a work in progress. And to circle back to our aims, we can say confidently that there is definitely somatic mutation within the placenta, and that this appears to be present in normal and abnormal placentas. This is a separate validation of the findings of the Oxford group. We are still uncertain as to whether or how these mutations or mutation patterns contribute to abnormal placental function. So this remains to be seen and will be assessed once we finalize that call set. These are our next steps. First, to finalize the call set, to disseminate our results. We have submitted 2 grants based on this work. The first was a K-23 to the NICHD, which was not funded. The second was a Burroughs Wellcome Fund grant in December that is a finalist for consideration, but we have not found out yet whether that will be funded. And I also want to acknowledge the very large group of friends and mentors that have supported this work and my personal career development, as well as the funders. So that will be all. Thank you very much.
Thank you, Nathan. And guess we don't have to worry about your disclaimer after the fact. When you do finalize these call sets, how do you see that information being used for the next step?
Thanks for your question, Dr. Berner. Really, that is just the very first step. I mean, it is, like you said, it's been an experience with a lot of exasperation getting up to this point, because it's taken almost 2 years of analysis to get to the point where we know which variants we think are real, and then we can do what we actually plan to do, which is try and figure out if they are important. So once we have variants that we can start to investigate, we can look at genes, biologic pathways, and ways that protein coding products are expressed and interact with each other. And I should say, we expect that this will really lead to some interesting insights in the way the placenta develops and works, and will be a important or productive line of inquiry. So it's once we get to that point where we can actually start to look into it, it's really will just be the beginning.
And it really is a fundamentally important line of pursuit, because when you think about all the things that a placenta is supposed to do and which it did to reasonable success for all of us at this meeting. There are just so many things that could potentially be going wrong along the line, that there's a whole career worth of several careers of research to pursue there. So we really appreciate your sharing your efforts with us, and keep the faith on this. You're on a good track, and we look forward to following your progress going forward.
Thank you.
And I'm going to move on to Rob Dude, who's our other current WRHR fellow scholar. And Rob was undergraduate at the University of Michigan, and then had a 9-year stop, all told, in Philadelphia for medical school, a Master of Science in Clinical Epidemiology degree, and then OBGYN residency. Followed that with a 4-year stint in Houston at MD Anderson for GYN oncology fellowship. We, as with Nathan, actively recruited Rob to come to Utah as a WRHR scholar, which we're fortunate that he agreed to do. It did turn out that he agreed to do that before COVID, and so having arrived in the midst of COVID has had more challenges to address than one might even expect otherwise in a first year in a new environment. But we're delighted that Rob is here. He's really upped the ante for research in our gynecologic oncology program, and he's going to tell us about women with synchronous uterine and ovarian cancers. Are they misdiagnosed and or mistreated? So let's roll Rob's presentation.
I'm Dr. Robert Dude, an assistant professor in obstetrics and gynecology within the Division of Gynecologic Oncology. And today I'm presenting on synchronous uterine and ovarian cancers, misdiagnosed or mistreated. I have no conflicts of interest to declare. Just quickly, because I'm still new around here, just my background and my mentors were here at the University of Pennsylvania for my OBGYN residency as well as my MD degree, and then was at the Anderson Cancer Institute most recently in Houston under Dr. Neil Sud and Karen Liu, and then just started here at the University of Utah Huntsman Cancer Institute in July of last year, working with these great folks and mentors. Background: first, we'll start with uterine cancer. It's the most common gynecologic malignancy in women in the United States, the majority of which present usually early at stage 1 when it's confined to the uterus, and of endometrioid histology, which is typically curable with surgery alone with an excellent survival and low risk of recurrence. For advanced stage disease, recurrence is high, however, so adjuvant therapy is needed in these specific cases. Ovarian cancer is the second most common gynecologic malignancy, but rarely diagnosed at early stages, namely 1 when it's confined to the ovary. It's most commonly a serous histology and rarely of endometrioid histology, which is a lower risk type. The majority, therefore, have a high risk of recurrence and receive adjuvant chemotherapy. In 2 to upwards of 20%, however, of uterine cancer cases, depending on the age, a synchronous ovarian cancer can also be found. The majority of these are dual endometrioid histology type. Therefore, most are low stage, low grade, low risk, and oftentimes just observed. However, they do pose a diagnostic challenge. Are synchronous primaries existing of both the ovary and the uterus arising independently? Or could these instead be metastatic uterine cancers that travel from the endometrium to the ovary, which is specifically stage 3A disease shown here in the diagram to the right? This could pose both a diagnostic challenge, but also have repercussions in adjuvant treatment. If misdiagnosis were occurring, we'd expect that we'd see women with synchronous stage 1 primaries with worse survival, closer to a stage 3A uterine cancer, or perhaps we might be over-treating these synchronous low-risk diseases. Therefore, my specific aims of this project, number 1, are to compare the survival of women with synchronous stage 1 cancers of the uterus and ovary to women with stage 3 uterine cancer in the SEER database. My hypothesis being that the women with stage 3A uterine cancer will have a worse overall survival. Next is to compare the survival of women with synchronous stage 1 cancers of the uterus and ovary to women with non-synchronous stage 1 cancers of the uterus or of the ovary. My hypothesis being that women with synchronous stage 1 uterine and ovarian cancers will have a worse survival. The methods for this study first included women in the SEER database from 2004 to 2015 with stage 1 uterine, stage 1 ovarian, and then stage 3A uterine cancers. For those unfamiliar with this data source, SEER is a US-based representative population-based database of patients diagnosed with cancer among the states shown here at the right, of which Utah is a member. The outcomes of this study are that cancer-specific survival in women with stage 1 uterine and ovarian synchronous cancers versus women with stage 3 uterine cancer and versus women with non-synchronous stage 1 uterine or ovarian cancers. We're looking at a number of covariates, namely demographic factors, as well as treatment and diagnostic factors, as well as specific factors to the patient's cancers. Luckily, we attained sufficient N for this study, given the rarity of both this stage as well as this synchronous primaries, but had over 500 women with stage 3A uterine cancers and over 930 women with stage 1 synchronous uterine and ovarian primaries. As is known and has been described in the literature, the women with stage 1 disease, and namely the synchronous stage 1 disease, tended to be younger when compared to the stage 3 uterine cancer patients. Interestingly, Asian and Pacific Islander women tended to be overrepresented in the stage 1 synchronous ovarian and uterine cancer group, and has been described in the stage 3 uterine cancer group. We see that Black women, known to be of worse outcomes and significant health disparity, tended to be overrepresented in this advanced stage group. Looking at the cancers themselves, first and foremost, the stage 1 synchronous cancers, given that they're an early stage, also tended to be of a lower grade 1 disease. And this is, of course, in contrast to the advanced stage 3A cancers tended to be of a higher grade 3 status. Nearly all women received surgery, as expected, given this is a surgically diagnosed and managed disease. And about half of women in the advanced uterine group received either chemotherapy or radiotherapy. About half of the women in the stage 1 synchronous uterine and ovarian cancer group received chemotherapy, and just a minority received radiotherapy. First, looking at overall survival in the synchronous group versus women with stage 3A disease, we do indeed see an expected survival benefit in stage 1 uterine ovarian synchronous cancers, shown in red, when compared to the stage 3A uterine cancers, shown in teal. Next, given, as I had mentioned, age tended to be different between these groups, we wanted to somewhat control for other causes of mortality, and then started looking at just cancer-specific survival. All groups are shown here. First, of note is that the survival benefit in the stage 1 synchronous uterine ovarian cancer group, shown in purple, was maintained within the cancer-specific survival, as they had improved survival when compared to the stage 3A uterine cancer group, again shown in teal. Of note, the stage 3A uterine cancer group did have somewhat of improved survival when compared to the overall survival, given that this is now just a cancer-specific survival. Now we are looking at the non-synchronous stage 1 ovarian cancer group, shown in red, and the non-synchronous stage 1 uterine cancer group, shown in green. And interestingly here, for the cancer-specific survival for the synchronous stage 1 cancer groups, when compared to these two groups, they had an improved survival, regardless of either uterine or ovarian cancer. We have been concerned that this could be due to confounding by indication, given that these might be lower risk histologies or grades or other factors. So we next restricted the analysis to those receiving any adjuvant therapy, which would likely select for all of the higher risk disease statuses. In the stage 1 synchronous survival, this benefit maintained its improved status. And then the stage 3A synchronous cancers seem to be unchanged, so they didn't really change restricting to this group, and that's because the majority received adjuvant therapy. And then interestingly, just looking at the stage 1 non-synchronous uterine cancer group, shown in green, they did tend to have a worse survival when restricting for the subpopulation of those receiving adjuvant therapy. This is likely simply confounded by indication due to, again, we're selecting for higher risk disease. So my preliminary conclusions on my first cut of this data are that women with stage 3 uterine cancer indeed had a worse survival than women with synchronous stage 1 uterine ovarian cancers. These trends continued in cancer-specific survival. Women with the stage 1 uterine ovarian cancers had a better survival than women with non-synchronous stage 1 cancers, regardless of adjuvant treatment. This suggests that misdiagnosis does not occur, given that a group of women with stage 1 synchronous primaries contaminated or misdiagnosed with stage 3 uterine cancers would likely have a worse survival than stage 1 uterine cancers alone, which we did not see. It is, however, important to note that we need to control for age, histology, and grade, given that the restricted analysis for adjuvant therapy doesn't really get to these fine points. Therefore, my future directions are to further investigate the demographic differences, namely in age, race, and ethnicity that I had mentioned, and really explore its interaction with histology, given we know that race and ethnicity and age tends to have increased risk for different higher risk histologies. I then plan to do some adjusted and sub-analyses for age, grade, and stage. And then I also plan to assess if adjuvant treatment is given to appropriate patients, really to explore for overtreatment. I do have some further studies, the first of which is underway, is to investigate tumor level or somatic genomic differences between these cancer groups using the M2Gen platform, which is a whole exome sequencing platform done for our center as well as a consortium of which we're a member. And then further, I plan down the road to investigate family-level differences between these cancer groups within the Utah population database. These are my references. And I'd love to extend my great thanks to my co-investigators, my mentors, and my funding sources. Thank you.
There's been more and more interest in self-injectomy, removing the tube altogether as a form of both sterilization and cancer prevention. And so, where do primary fallopian tube cancers fit into this this synchronous model?
Yeah, so interestingly, the majority of cancers that we think come from the fallopian tube tend to be serous cancers, either high or low grade. However, in this synchronous group, they tend to be kind of cancers that come more of the parenchyma of the ovary itself. So the endometrioid histologies or mucinous tended to be most represented, as well as clear cell. But certainly I think that it is a kind of a thought or a pathway of, much as we had thought that the fallopian tube primaries start in the fallopian tube and then are really technically a drop met, say, onto the ovary. It's certainly understandable and thoughtful that that could be kind of the mechanism of, say, stage 3A cancers, where it indeed is a metastasis that starts in the endometrium, travels into the fallopian tube, and then drops itself onto the ovary. So not in kind of, doesn't follow kind of the typical patterns that we think about primary fallopian tube cancers, but certainly is something to think about for the mechanism.
Okay, great. Well, thanks both to Rob and to Nathan for great presentations and for continuing their research careers. And I'm going to take us on to the next section here. When we were started planning for this year's symposium, we were already in the throes of what at the time we thought was a real pandemic. And obviously we had no idea of how real it was going to get by the time we got to this point. But it was clear even then that we needed to address COVID and its impact on women's health. And so the next hour, the next three talks are going to be addressing various aspects of COVID infection and women's health. As a momentary aside, for those of you who are interested in CME, continuing medical education, well, hopefully you've all seen the link that was in the attachment that Leanne sent around this morning. If not, we'll let Leanne and I know, and we can get it to you. Part of the reason to mention that is that for the next 20 minutes will be a CME-free zone as a result of some things that Dr. Metz is working on with Pfizer. But we're delighted that Tori has agreed to talk about COVID-19 and pregnancy and what do we know at this point. Tori has sort of bounced back and forth across the Rocky Mountains as a medical student and resident at Colorado. We were fortunate to lure her here for a MFM fellowship, and then she went back to Colorado, Denver Health and University of Colorado for 6 years. But we've fortunately, we hope, gotten her last move for her career and getting her back here in 2018. She's the vice chair for research for the OBGYN department, is the Utah site PI for the MFMU network, and is in that capacity as well, hopefully soon to be able to report on what should be the definitive series of pregnancy complications and outcomes with COVID infections through that mechanism. And with that, I will ask Nancy and Leanne to roll Tori's presentation on COVID and pregnancy.
Thank you so much for inviting me here today to talk about COVID-19 and pregnancy. What do we know now? I do have a disclosure. I participated in the Medical Advisory Board and am a site principal investigator for a Pfizer COVID-19 vaccination and pregnancy trial. The objectives today are to describe the anticipated outcomes for individuals with COVID-19 infection during pregnancy or postpartum, and to discuss the available data regarding SARS-CoV-2 vaccination and pregnancy. The first question I'm going to answer today is, do pregnant individuals have a greater risk of severe illness than non-pregnant? These data are from an MMWR report of cases that were submitted to the CDC from January 22nd to October 3rd, 2020. They had about 1.3 million reproductive age females who tested positive for SARS-CoV-2 that were included, and they had data on pregnancy status available for 36% of these reproductive age females. So this is one of the criticisms of these data, is that they just did not know pregnancy status on a large portion of the cohort. But among those with pregnancy status information, 89% were symptomatic, and among those symptomatic females, 5.7% were pregnant. From that data, they looked at risk with pregnancy, and they found that after adjustment for age, comorbidities, and race ethnicity, pregnant women were at increased risk of ICU admission, mechanical ventilation, and death. They also noted that disparities were prevalent, which we've also seen in other literature. And in this data set, Black women, although Black women only represented 14.1% of the cohort, they represented 37% of the deaths overall and 27% of the deaths among pregnant women. We're just going on a whirlwind tour here. So the next question I'm going to answer is, do pregnant patients with COVID-19 have greater risk of complications than those without COVID-19? These data are from a retrospective cohort of all deliveries from April to November, and an all-payer database that encompasses about 20% of the US population. For this study, they identified participants with billing codes, and so specifically billing codes for COVID-19. And their total N was just under 500,000 patients who were hospitalized for childbirth. Among them, 1.6% of them had a COVID-19 diagnostic code. And then they went and looked at those with COVID compared to not COVID. And again, this is just billing code capture. And what you can see is the with COVID group here has about 6,300 people, and the no COVID about 400,000. And you can see that there are increased risks among those who had a pregnancy hospitalization, who had COVID. There was an increased risk of preterm labor, preterm birth, stillbirth, preeclampsia, eclampsia, HELLP syndrome, venous thromboembolism, ICU admission, and need for mechanical ventilation. And those really did, the majority of them, with the exception of eclampsia and stillbirth, hold up in multivariable modeling. Now I'm going to move on a little bit to maternal and neonatal outcomes. I'm going to focus on the study and the work that we've been doing through the National Institute of Child Health and Human Development Maternal Fetal Medicine Units Network GRAVIT study. The MFMU consists of 12 centers and 33 individual hospital sites across the United States. And you can see here we are in Utah, kind of the Lone Rangers in the West here participating in this network. But we began to study COVID and pregnancy very early in the pandemic. The GRAVID study is continuing to enroll patients because we're looking more globally at the effects of pandemic on pregnancies in general, not just among those who actually contracted SARS-CoV-2. But we did put out some initial data based on the first 1,219 patients that were identified with SARS-CoV-2 who were pregnant or postpartum in the network. Notably, 53% of them were Hispanic, which is a much higher proportion of Hispanic patients than are typically in our studies, again, demonstrating the disparities in acquisition of the SARS-CoV-2. And when we compared people who were asymptomatic with those who had severe or critical COVID-19, we found that severe and critical COVID-19 was associated with an increased risk of hypertensive disorders of pregnancy, so things like preeclampsia and gestational hypertension, cesarean delivery, which is here, and preterm birth. Also, we found the maternal death rate was about 0.3% in our cohort in terms of deaths that were attributable to COVID-19. We eventually concluded, based on this cohort, that severe and critical illness with COVID-19, but not mild or moderate illness with COVID-19, was associated with adverse pregnancy outcomes. So I think these data are important in that we can tell patients that if you are very sick with COVID, that you do have higher risks of all these adverse pregnancy outcomes, hypertension, cesarean, preterm birth. But fortunately, those that had more mild illness, really, we did not see these increased risks of pregnancy, adverse pregnancy outcomes. So I think we can be reassuring to patients who are able to be managed in the outpatient setting because they're not ill. So what about stillbirth? Stillbirth appears to be rare, but has been reported in the setting of maternal critical illness and multi-organ dysfunction. There was an initial limited single hospital UK evaluation that demonstrated increased stillbirth during the pandemic compared to prior to the pandemic. But there was then a subsequent study across the whole UK that demonstrated no increased risk of stillbirth. And just to show you those data of that second study, they're here. And so this is really looking at monthly count of deliveries with a record of stillbirth. So stillbirths over the time period of 2019 with a lead-in to show you the baseline rates, and then 2020 during the pandemic. And then really blocking off this COVID lockdown period here from April to June. And what they saw was no increased incidence of stillbirth. And so they kind of backtracked on this idea that we may be seeing more stillbirths than prior to the pandemic. There is a lot of interest, not surprisingly, in whether COVID-19 can be transmitted vertically. Vertical transmission likely does occur, but it's extraordinarily rare. There are case reports that are very convincing for a case of vertical transmission, but it's certainly not the norm. We do not see it frequently. SARS-CoV-2 RNA has been isolated from the placenta, though, even in cases without fetal infection. We think that's because the placenta expresses the ACE2 receptor. And there are also histopathologic changes. So histopathology does show evidence of placental damage, often even in the absence of a placental infection. But this isn't universal. But we do worry about the offspring of these women that have SARS-CoV-2 and whether it will affect their development in any way, because we are seeing some placental effects, especially in patients who have more severe infections. COVID-19 and preterm birth is another hot topic. There are very mixed data on this, but there were a couple studies that came out early on suggesting that preterm birth was actually decreased during the pandemic. There was a study out of Denmark that demonstrated a reduction in births less than 28 weeks during the pandemic, going from 0.9 per 1,000 to 2.19 per 1,000 pre-pandemic. There was also a study out of the Netherlands that was a single center study showing a decrease in very low birth weight. So another corollary of early birth, demonstrating that it looked like that had gone down. But then there was a UK study showing no difference in preterm births. There is also a United States study from 2 hospitals in Philadelphia looking at pre-pandemic compared to during the pandemic. They had about 9,000 deliveries and about 3,000 of them were during the pandemic. And they similarly saw no difference in preterm birth, 10.5% pre versus 9.5% during, and no differences in stillbirth. So the question is, has the pandemic lowered preterm birth rates? There are some population-based studies that demonstrate a decrease in preterm birth during the pandemic, but there's others that don't. The mechanism for this would be unknown. There was a lot of discussion of whether there are environmental changes or other things that we could identify that perhaps could help us decrease preterm births in the long term. But really, we're not quite ready for that. This needs some further study. The data out there are pretty mixed. And really, there are not any population-based US data at this point. So just briefly touching on COVID-19 and maternal mortality. This is one of the focuses of the NICHD MFMU Gravid study. We're really looking and delving into severe maternal morbidity and mortality during this time, both related to COVID-19 itself, as well as women in general during the pandemic. There are some data out of the US. I told you that in the Gravid study, the MFMU Gravid study, our maternal death rate was 0.3%. These are data from a case series of hospitalized pregnant and postpartum patients with COVID-19 who were admitted to the ICU in 10 different hospitals in New York. 19% of those with severe or critical COVID-19 by the NIH criteria, there are actually classifications for that, were admitted to the ICU. 2 died and 11 were discharged from the hospital, which gave them an overall mortality rate of 0.2%. So very similar to what we found in our study as well. Notably, that doesn't sound that high, but it is certainly much higher than what we expect from other viruses and other pregnancy complications. And so it is certainly still concerning and something that has drawn a lot of attention. I think also we haven't even begun to delve into indirect deaths during this time. We know from early data that emergency department rates really declined about 50% early in the pandemic. And it remains unknown if pregnancy-related deaths secondary to things that would normally bring people to OB emergency services like severe hypertension, stroke, sepsis, and overdose with the stress of the pandemic have increased as well. People are concerned that they may have. And so we've really asked people who do maternal death reviews, like we do here in the state of Utah, to really consider pandemic effects for any deaths that occurred in 2020. And so not just thinking about the direct effect of a COVID-19 death, but also indirect effects because of lack of access to care during this time. I felt like it would be important to touch on COVID-19 vaccination. This is certainly where a lot of the science is happening right now related to COVID and pregnancy, and where a lot of the media attention has been. So I think the initial question is just, is vaccination in pregnancy allowed? Under the emergency use authorization for the Pfizer and Moderna vaccine, there's not a restriction based on pregnancy or breastfeeding status. So yes, it is allowed. And all of the guiding organizations related to OBGYN recommended shared decision-making for mothers with their healthcare providers regarding whether to proceed with vaccination in pregnancy. Initially, this was really hard because there really were not safety data out there, and we are just starting to get safety data for pregnancy because pregnant women were not included in the initial trials. There was just recently a publication that came out in the New England Journal of Medicine with some initial CDC and VAERS data. And so they combined both of these into one paper. There were 221 adverse events that had been reported and 46 cases of spontaneous abortion. There were, and VSafe, which is just the app that people sign up for when they get their vaccination. Hopefully a lot of you did that. There were 35,691 VSafe participants who received the COVID vaccine in pregnancy. So if you remember, if you use that app, it asked, were you pregnant when you got the vaccine? And so they looked at data from December 14th through February 28th of 2021. They found that participants who were pregnant noted that they had headache, myalgias, chills, fever less frequently than that when they were pregnant versus non-pregnant. But pregnant patients did note that they had injection site pain more frequently. There were 3,958 who participated in VSafe pregnancy registry. So CDC reached out to patients who said they were pregnant and asked them for more information about their pregnancy. 827 of them at the time of this publication had completed pregnancies. 14% of them resulted in pregnancy loss, 9% preterm birth, and 3% small for gestational age, and no neonatal deaths. And so despite not having a good comparison group, they can at least compare these two population estimates and did not identify any safety signal. These are all right around or below baseline risks. There are also a lot of news articles recently about COVID antibody transfer from vaccination and pregnancy. There are a number of articles about this. This is the most recent and largest one that I think gives a little bit more detailed data about this. They looked at 122 women who received mRNA vaccines, either Pfizer or Moderna, for SARS-CoV-2. None of them had prior SARS-CoV-2 infection, and they looked at both maternal and cord blood. And what they found is that the earliest neonatal passive immunity that was detected at about 16 days post-vaccine dose number 1, so meaning that 16 days after the mom's first dose of a vaccine, there was detectable antibody in the baby's cord blood, demonstrating the antibodies had crossed the placenta and were protecting the baby. And these are just that data in a little bit more detail, showing you weeks elapsed since dose 1. And these darker ones are cases in which there's passive immunity. So it's in that 2 to 3 weeks after the first dose that the babies start to get protection from moms. And not surprisingly, there was really nice correlation between maternal levels of antibody and neonatal levels of antibody. So that a lot of patients have seen this and are excited to think about the fact that they may also be offering some protection to the neonate. So I'm going to wrap it up there. I feel like that was a complete whirlwind tour, but it's a short time. I'm very happy to take any questions. I do want to thank the Eunice Kennedy Shriver NICHD for funding the MFMU Gravid study that I spoke about with you today, as well as their ongoing funding for COVID studies in general. So thank you so much, and I look forward to your questions.
Thanks for a great talk, Tori. I'll start off. What about vaccination and breastfeeding? A little bit downstream from pregnancy per se, but what advice can you give us on that?
Yeah, there have also been some data, although a little bit smaller numbers than the pregnancy data, but some of the cohorts are mixed and looked at both pregnant and breastfeeding patients and found that we are also seeing antibody passing into the breast milk. There's actually been a number of New York Times articles about it, and cases where actually patients who had stopped lactating have tried to start lactating again because they've been so excited about the opportunity to potentially transfer antibodies to neonates, because it's going to be a long time, if ever, that we're down into that neonatal range. I think, both Pfizer and Moderna are going down to 6 months now as sort of their next set of trials. But those really early babies are looking for protection either from pregnancy, immunization, or during lactation.
Dr. Metz, I had a question, and my internet was a little bit in and out, so I'm sorry if you already addressed it in your talk. For the women who had severe COVID infections, were there any identifiable risk factors for those that we could identify, like patients in clinic or something? I know you had mentioned the ethnicity and the race, but there may be disparity in care. I'm curious if there were any identifiable risk factors.
Yeah, and I mean, in terms of the race and ethnicity, what we did see is a higher prevalence of SARS-CoV-2 in the communities of color, not that when they contracted the virus that they became more ill. So I think that that's one thing that is important. It's more that this virus has really disproportionately affected communities of color in terms of acquisition of the virus in the first place. In terms of disease severity in the pregnant population, we are seeing the same things that we see in the non-pregnant population. So people who have underlying comorbidities, especially obesity and chronic hypertension, are at much higher risk for having severe disease. And so I definitely speak with my patients about that, who are thinking about whether they want to get vaccinated in pregnancy. If they have additional risk factors for severe disease, I definitely speak with them about that. Pregnant women in general, we think, are at higher risk for severe disease from the CDC data, although I am aware of the Annals article that came out yesterday looking at mortality, and I sort of called that into question. But I think there's limitations of that Annals article as well, because more than you probably want to know, but the Annals of Internal Medicine article basically looked at all hospitalizations and then sort of looked at if people went to the ICU or if they died during the hospitalization. I think that the denominator in the pregnant group is really inflated because we have a much lower threshold to admit them to the hospital. So it's a little bit tricky to interpret those data. So the CDC data have limitations, so do the new data. So, but I do talk to patients about, with other viruses, they are at much higher risk for having severe disease, and that needs to be weighed.
Well, thanks very much, Tori.
Thank you.
Our next presentation is from Scott Benson, who's in the faculty in the Department of Family and Preventive Medicine's Public Health Division. His primary focus has been on global health, and I think, Scott, if there were a prize for the most circumlocuitous career trajectory, you'd be a serious contender. But Scott has a MPH from the University of Utah, a PhD in Civil and Environmental Engineering from Utah State, back to the U for medical school, residency in internal medicine, and a fellowship in infectious diseases, and as I mentioned, a particular interest in travel and tropical medicine. And so Scott has graciously agreed to talk to us about sex and gender differences with COVID-19. So let's roll Scott's talk.
Hi, my name is Scott Benson. I'm an associate professor in the Department of Family and Preventive Medicine here at the University of Utah. I'm an infectious disease doc, and I specialize in global health and tropical diseases. I'm going to talk to you a little bit today about COVID-19 impacts and sex and gender differences. Now, by way of disclaimer, our understanding of COVID-19 right now is still relatively fresh and new, and the things that I talk about today are to the best of our knowledge, and they may and probably will be changing a little bit over the next few years. So as we learn more, some of the things that we talk about today may be disproven or really go out of date. I also want to recognize that sex and gender describe different characteristics. For the purposes of this discussion, we're going to talk about sex in the biological sense of male and female. And while I recognize that there is a spectrum of gender identities, at this point in the literature, there is not enough information to really provide information on gender differences across the spectrum in response to COVID-19. So with that caveat, let's begin. First, I'd like to talk about how the infection occurs. COVID-19 utilizes a couple of mechanisms to infect the human cell, typically the epithelial cell. The most important components are the ACE2 receptor and a protein called the transmembrane protein receptor for serine 2, or TMPRSS2. Those two receptors combine and allow the COVID-19 virus, or SARS-CoV-2, to invade into the human cell, typically an epithelial cell, and begin replication, thereby causing infection. Now, while there are other players that are important in this activity, like trypsin and other proteases, the primary two that we are most concerned about at this point are the ACE2 receptor and TMPRSS2, or the serine receptor number 2. So what then becomes important is where in the body are these two receptors, or the receptor and the protease, located? They are, as you can see in this description, this figure here, really they are found throughout the body. One of the things that we've recognized over the course of the past year as we've learned more about COVID is that while we've considered it a pulmonary or a respiratory disease, it's much more of a vascular disease, and it can attack the endothelial walls of tissue anywhere. It's just that we first recognized it in the pulmonary tissue because it is so vascular. But really anywhere that there's an epithelial layer, COVID can attack. You can see here that almost all tissues, and now with the past year's worth of history, we've seen almost all tissues impacted through the literature at one degree or another. Now, there are a few interesting caveats. You'll notice that a lot of the immunogenic tissues, bone marrow, spleen, lymph nodes, we have not well described finding ACE2 receptors in those tissues. Similarly, the testes, the male testes, it's been contradictory. There have been some studies that have found ACE2 receptors and others who have failed to find it. So there are still a lot of areas that we don't quite understand the distribution of ACE2 receptors and the serine receptors throughout the body. Now, what that tells us, though, is that in areas where those receptors are, the infection can occur and impact the pathophysiology of the patient. Over the course of this pandemic, we really learned a lot. In March of 2020, when I was giving discussions about COVID-19, these are the numbers that I cited. In Italy, the male-female coronavirus cases and deaths were predominantly men. 60% of coronavirus cases, 70% of deaths at that time were male over female. In China, the initial reports were that 64% of deaths were in men. Now, originally, some of the theories were that these male to female predominance of deaths and cases was because more men smoked in China. However, over the course of the year, we've made, with additional studies, additional countries, larger populations, we've noticed some changes in those demographic numbers associated with COVID. What we now see is that the cases of COVID are essentially equal between men and women. That men and women are infected at approximately the same rate. However, for every 10 women, only 8 men get tested. For every 10 women who are hospitalized, 11 men are hospitalized. For every 10 females that are entered into the ICU, 18 men are admitted to the ICU. For every 10 females that die related to COVID, 13 men die. And for every 10 women that get a vaccine, only 9 men seek the same vaccination. So there's this funny dichotomy of it appears that the mortality and the severity is worse in males than it is in females. Now, why is that? There are a number of theoretical explanations. We're still in the mode where a lot of our information comes from observational studies, animal studies, in vitro work, and we don't have a lot of human descriptive studies. So what I'm about to tell you, some of the discrepancies between male and female response to COVID are just that. They're theoretical at this point, and they may or may not explain the actual differences that we observe. First, there's a difference in the distribution of ACE2 receptors. There are differences in where these receptors are, and in general, men are felt to have more ACE2 receptors than females in general. When we look at animal studies looking at the presence of ACE2 receptors, we notice some discrepancies and some influence of sex hormones on the generation of ACE2 receptors. If you take male rats and do an orchiectomy, it reduces the ACE2 receptor quantity in the male rat. Correspondingly, if you take a female rat and do an ovarectomy, it increases the ACE2 receptors in the female rat. So there is some suggestion in the animal model that sex hormones have an influence on the expression of ACE2 receptors. And if that's the case, that may be one of the reasons why we see the difference in severity and mortality between men and women. A second reason is there appears to be some crosstalk between the TMPRSS2 serine receptor and androgen receptors. In fact, when you look at the DHT transcription, it influences the presence of that serine receptor. So while it's not clearly elucidated, we do know that men who have prostate cancer seem to have a lower severity, lower mortality due to COVID. And so there is this question of androgen receptor role in the transcription of DHT and how that might play a role in the COVID response. There's also a really interesting theory about nitric oxide release, which in and of itself serves as a mechanism of the immune system to clear pathogenic particles. And when nitrogen oxide increases estrogen via the estrogen receptor protein. And so when there's an upregulation of estrogen, you see an upregulation of nitric oxidase and nitric oxide production in that cells, which may lead to a protective quality to the females who have that increased nitric oxide production. So those are three of the major mechanisms that we presume at this point provide some benefit to females over males. There are some others that there's really some question about. There's the role of the X chromosome in infections. We recognize that the X chromosome carries a lot of immunogenic genes, and that can be both a curse and a blessing, in the sense that typically when there's a duplicative gene, there's a suppression, an inactivation of one gene, allowing the normal immune response. However, when that fails and there's a hyperimmune response, that's one of the mechanisms felt to be associated with autoimmune disease. But that suppression and that hyperpotential immune response may be one of the reasons why we see a difference in the way men and women respond. I know that the sexual dimorphism is falling out of favor significantly. And so a lot of these things, the immune response, is a big question, and we just don't quite understand. When you look at the immune response, our studies to date have shown that females demonstrate a higher and longer IgG response to a COVID infection. They seem to demonstrate a better take on the vaccine. So that would suggest that the immunological response in females is better than that of males. Now, that being said, of the roughly 9,245 individuals who have reported to the CDC that they acquired a COVID infection after complete vaccination, 5,827 of them, or 63%, are female. So while on the one hand, females appear to respond better to vaccination and infection through an immunological process, there's evidence that, at least in the small numbers of the studies of the CDC, that they are acquiring COVID after vaccination, which I don't quite understand. Then there have been described some cardiovascular disease differences. This is strictly observational, and at this point I don't put a lot of stock in those differences that are described. So when you look at the mechanisms so far that appear to provide the strongest evidence of pathophysiologic difference in the way that women and men, females and males respond to COVID, it's the ACE2 distribution, the tissues in which ACE2 is found, the androgen TMPRSS2 response to androgen crosstalk, and the overall greater immune response in females greater than males. And so those three mechanisms appear to be the mechanisms that provide a significant pathophysiologic difference in the response. Now, when we look at the individual response pathophysiologically, that's only one of the differences and impacts that we see. Perhaps larger than the pathophysiologic response that occurs in the individual is the social impact that we're seeing as a response to COVID today. Recently, the National Academy of Sciences produced a rather extensive document that talked about the impact of COVID on our current population of specifically women in science, technology, engineering, and medicine fields. In a recent survey, they found that 27% of women reported an increased workload or work hours, a 25% reduction in their overall productivity, a 20% increase in difficulty interacting with their peers, and an 18% decrease in an 18% increase in adverse effect on teaching and research. In fact, one woman was quoted as saying that as a professional engineer working in academia and as a single mother of 3 girls, the pandemic has radically changed everything. I simply do not have the mental bandwidth to be a full-time homeschooling mom, housekeeper, instructor, researcher, and family member. Another indicated that most institutions responded well to the pandemic by offering remote work, stopping the tenure clock and allowing them to choose their method of teaching. That in and of itself poses problems in that women who are on the tenure track are all of a sudden set back a full year. And whether the policies and procedures of institutions were ready for this pandemic appears not to be the case in a majority of cases. And in fact, many non-tenured individuals face specific challenges and negative impacts on their work because of the heavy course load and the bandwidth required to switch from in-person to online coursework. It's been speculated that we may lose an entire generation, at least a year, of women in academic pursuits because of COVID-19. Now, stereotypically, women have been asked to take on the responsibilities of caring for kids at home, in addition to their work responsibilities. And when working from home and caring from home, many are finding it a challenge that's complicating their advancement. Another important factor that's been reported is an increase in intimate partner violence. When you look around the world, Chile has reported a 70% increase in reports of intimate partner violence. Argentina, a 67% increase. Globally, it's about a 36% average increase in partner violence in the 3 months following a lockdown. Now, in the United States, we don't have a lot of numbers yet. These studies are ongoing, but it suggests that somewhere between 10 and 27% increase in calls for domestic violence in the time after a lockdown is imposed in response to COVID. So are there sex and gender differences? Well, we can answer that yes. We can't explain them all. We can see that there are mortality and morbidity differences where men are impacted greater than males are impacted greater than females. However, there are pathophysiologic mechanisms that may explain the reduced severity of disease in females. But in addition to the pathophysiologic differences, there are also important social differences, and the outcome of the social differences may end up being the longer lasting impacts of this COVID-19 pandemic. Thank you for giving me a little bit of your time. It's been a pleasure to speak with you today. I'm happy to answer any questions. Bye-bye.
Scott, that was a terrific presentation, and I just want to first specifically commend you for your comments on intimate placental, my slip is showing, intimate partner violence and on career impact. Those are really important issues. And at some point, I think there's probably 40 of us who want to know how you did that visual. So maybe you can drop that in the chat if there's a program. That was terrific. Other folks with questions, comments for Scott?
Thanks for having me.
Okay, well, thank you very much. That was terrific. Amazingly enough, almost 3 hours into this, we remain right on time. And so thanks again to all of the presenters for their pre-recorded talks. And the final COVID in women's health presentation today is by Dr. Anu Asnani from the psychology department. Dr. Asnani comes to us from the Eastern Time Zone. She was a graduate student at Boston University and then on the faculty at the University of Pennsylvania in clinical psychology for 5 yeers. And we've had the good fortune of having her here in Utah since 2019. Her research interests are focused on a better understanding of mechanisms for impacting change in fear-based symptoms and improving outcomes that matter on communities and reducing ongoing health disparities. And we have the good fortune of having her talking to us this afternoon about the impact of COVID-19 on mental health of diverse communities. So thank you for joining us, and I look forward to your presentation.
Hi everyone, I'm Dr. Anu Asnani. I am an assistant professor in the Department of Psychology at the University of Utah, and I am presenting today in my capacity as also a licensed clinical psychologist and a researcher who has had the pleasure of working with several communities here in Salt Lake City over the past year on mental health needs. I am presenting today, and my student, Karen Kaur, has been very involved in this work as well. She will be with us for the question and answer session as well to answer any questions that come up from this presentation today. So we're going to be talking about the impact of COVID-19, specifically in terms of the emotional well-being of diverse communities, many of whom are women, but certainly not everyone identifies as a woman across these communities, but we thought that it was an important and timely addition to what's being discussed today in today's series of talks. So let's get into kind of describing what it is that we did and why we did it. So, we know that there's a lot of health disparities in general, but there is a lot of mental health disparities in terms of diagnosis, treatment options, access, and education in diverse cultural and racial ethnic minority groups, both in Utah, but in general across the country. So health disparities don't exist in a vacuum. They exist due to many other factors that are ongoing on, socio-political factors like poverty, discrimination, and language barriers, and a lack of culturally competent mental health providers. And then certainly when you have these ongoing current kind of phenomena, those further impact and compound the mental health disparities that already exist. So things such as the COVID-19 crisis has accentuated really these disparities in the mental health domain due to disproportionate rates of COVID-19 infection in culturally and racially, ethnically diverse communities, significant isolation and deviation from community-oriented activities, which are really central to a lot of these communities. And so that was kind of the context in which, we had started doing this mental health work and mental health outreach work with communities in Utah prior to the pandemic starting, and certainly it became very clear that understanding what COVID-19 was doing was going to be really important to our work. So I'm going to present a little bit on a study that just wrapped up actually just about 2 weeks ago. It was a 1-year pilot study that was funded by our University of Utah CCTS, which received funding from NIH's NCATS, and my team and I received this funding to really understand what was going on for our communities. And we partnered with this excellent community organization called Community Faces of Utah, whom several folks have partnered with to better understand the mental health needs in the communities here in Salt Lake City. And for those who don't know, the CFU is made up of 5 different partner organizations who serve different communities: the Best of Africa organization serving African immigrants and refugees, Calvary Baptist Church, which primarily serves African Americans, though others as well who attend that church, Hispanic Healthcare Task Force, who my co-PI for this study, Dr. Ana Sanchez-Burkhead, is the president of, National Tongan American Society of Pacific Islanders, and the Urban Indian Center, which serves American Indians and Alaskan Natives. And so we had 2 kind of phases that we had come up with, again, prior to the pandemic coming on, and then we quickly pivoted and incorporated understanding what the pandemic was doing to mental health. But in phase 1, which happened right as the pandemic was starting last summer, was to do these focus groups, which we ended up doing virtually instead of in person due to the pandemic, but still were able to meet basically with all 5 communities. We had about 48 people across the 5 communities, so 8 to 10 in each community, to ask about mental health definitions, priority areas, barriers, and impact. And then we followed this up with this phase 2 data collection of quantitative survey of community members, 61 community members, and then we also extended to providers, individuals who identify as providing mental health, emotional health support in these communities. In terms of the same, we got the survey of the same topics and the impact of COVID-19 on their own and others' well-being and stress. We wanted to get a sense. And really the long-term goal of this work and this pilot grant was to try to bring resources both directly to communities and to their providers. So whether those were community health workers, CHWs, peer supports, life coaches, spiritual advisors, and to try to figure out together how we can manage mental health concerns, particularly those stemming from COVID-19. So what did we find? Let me talk a little bit about what we found in phase 1 focus group findings in each of the communities. So for the Best of Africa group, what really came up as the downsides of COVID-19 are some ones that we've seen in other communities: financial concerns, a lot of anxiety about the uncertainty about what it means to get the disease, not being able to physically touch and hug other people and being restricted from doing that. The Calvary Baptist Church mentioned some very logistical things that happen as due to the pandemic, like losing their actual church therapists, the really big impact on seniors, greater increase of senior depression because they were isolated, lack of socialization, lack of being able to come to church. The Hispanic Healthcare Task Force also talked about similar themes of occupational and financial concerns, anxiety, and a lot of misinformation concerns that would really throw things off from an emotional standpoint. And then the National Tongan American Society of Pacific Pacific Islanders talked about, losing family to the virus. And so a lot of grief in that community, a lot of anxiety over the family getting COVID, as we saw in the others. And the Urban Indian Center talked a lot about feeling lonely, fear and anxiety, feelings of uncertainty, and not being able to touch others. So we see some common themes across the groups. One important thing I want to mention is that our community leaders, who we work closely with to both recruit and then deliver these focus groups, they were the facilitators for these focus groups, asked us to ask about pros. What are some of the advantages or silver linings of the COVID-19 crisis, which we hadn't thought to ask. And so I thought that was really interesting. And Best of Africa group talked about that they actually were getting more time with their family, time to work on their own mental health and self-care. And we saw this as a theme. The Calvary Baptist Church said the same, that we're being forced to learn some healthy coping mechanisms, go back to writing, go back to praying. The Hispanic Healthcare Task Force did not note any specific pros, but we saw again with the Pacific Islander community, family self-improvement, learning more about health and resources, and the Urban Indian Center talked about a lot about coming into finding ways to cope, more time to learn new things, people being more considerate and caring, and meditation and things like that. So very interesting to see the pros, that not everything is bad about it. When we go into the survey, we have bigger numbers here. We're able to see, just ask how much has COVID-19 affected your emotional health, and we see this, that the vast majority, as expected, are saying a little to a lot. Just one caveat about our Urban Indian Center, we did not get many community members to do the survey portion as opposed to the focus groups. So this is only 2 people, 100% of 2 people, but the rest were all about 14 to 15. I think there were 15 community members from each. So just to give you a sense of the ends that we're looking at here. We also asked them, in what ways has COVID-19 caused you emotional stress? The most common being socially distant from others, feeling socially isolated, not having those community or religious events, and then about a half reporting feelings of those uncertainty. So some of that confirmation from the focus groups and that job loss and financial hardship, a little less. You'd see it more in certain communities, but as a whole, it was about a third of the sample. And how much, now asking the providers, how about for you guys, how much has the COVID-19 pandemic affected your emotional health? 90% in the Best of Africa, and then about half in the Hispanic and Pacific Islander groups. And we also actually surveyed an additional 31 just community health workers affiliated with the Utah Department of Health, and a huge number of them said that they were really being affected by COVID-19 in their own emotional health as providers. So where do we go from here? As I finish up today, thinking about what is going to be the next steps when we think about COVID-19 is going to continue. Emotional health issues preceded the pandemic and will continue after the pandemic, but they're certainly compounded and certainly exacerbated by this pandemic. So we actually just put in a grant to PCORI, the whole team as a community research team. We applied for significantly larger amount of money this spring to provide training and support. Now we're thinking specifically to our community health workers who themselves are feeling quite stressed by the pandemic on managing the emotional toll of COVID-19 in our communities. So this will include some direct provision of resources skills. We're going to be doing some comparing 2 different trainings of evidence-based strategies for managing emotional and social stress of COVID-19. And it will also kind of take this 2 levels of analysis at the provider and participant level. So we're training CHWs who will be able to do this work, and then we're monitoring what happens to the patients, i.e. the community members that they're treating. So how do these mental health strategies impact adherence to COVID-19 public health guidelines? If people are feeling more emotionally kind of equipped, are they able to follow the guidelines to keep themselves and their families safe? How does it impact provider burnout and provider efficacy or feelings of effectiveness working with these communities? And so for this work, we're partnering with the Utah Department of Health to provide the training. And we're also doing some other work, just not even outside of the study. We're trying to partner and provide, even before this study gets funded, of how we can bolster some of their mental health training and mental health supports for the communities. And then a big part, which I just want to make a plug for, so so important when we're doing community-based participatory research, community-based work, is going back to the communities. We promised that in our pilot grant, and it's already in motion. We have a program set up with all 5 communities to go back and tell them what we found from our focus group and survey data, what we plan to do, and what do they think about it, and get their input, the community's direct input on whether the approach is useful, helpful, so that we can continue to provide services that are most helpful for what the community is actually saying, that the communities are actually saying that they need. So I just wanted to say thank you. We're happy to answer questions that come up. And if we don't get to any questions that you had in the Q&A that come up later, that's our contact information there. But a huge thank you to our CFU family, for which we can't do any of this research without them. So Ana Sanchez-Burkhead, my co-PI on this particular pilot grant, and then our community Faces of Utah leaders, Valentine Mukundende, Edwin Napia, Fahina Pasi, Jeanette Valalta, and Darina Lee from the 5 different CFU communities. My lab, the Treatment Mechanisms Community Empowerment and Technology Innovations Lab at the University of Utah. So particularly my students Manny Gutierrez Chavez, Tracy Takana, and Ifra Majid, who have been really instrumental with Karen in being able to do this work. And Karen and I are very, very thankful for that. And then our community collaborative engagement team that connected us with CFU, so Louisa Stark and Heather Brown in particular. So happy to answer any questions that you have, and thank you for your attention today.
Great. Thank you. That was really a very informative and interesting talk. You know, there is a lot of talk about vaccine hesitancy, vaccine referral. Did you collect any information on those perspectives in your study?
So, Michael, we didn't have any direct questions on vaccinations, but we did have a lot of responses of community members feeling hesitant, particularly regarding the information regarding vaccinations, and feeling that some people were saying, you know, this conspiracy theory that there might be a chip in vaccinations, or that the vaccinations might cause COVID-19. And so there was definitely hesitancy in getting the vaccine across all communities. And community health workers also identified, when we had focus groups with them, that they did have some patients who were hesitant in getting the COVID-19 vaccine, which is also something that we are implementing in our grant that we've submitted to address adherence to public health guidelines, and whether receiving the evidence-based strategies increases how confident they feel in adhering to and following guidelines.
Other questions for Dr. Asnani? Well, thank you very much. We look forward to following interesting results, and good luck with that grant submission. Hopefully we'll see results from that as well. I wanted to take just a moment to reemphasize the poster sessions that we have ongoing. Over the last several years, we've had a call for posters from various members of the COE and university communities. We had another excellent turnout again. Leanne Johnson just put the YouTube link in the chat again for all of you, and I'd encourage you to take a look at those again. The planning committee, after the posters had been submitted, looked at all of them, and similar to last year, we selected for this one 4 of the posters that we thought would be the most interesting and informative, and asked those authors to do a shorter recording for what we've come to call the data blitz. And so I'm going to ask Nancy and Leanne if we can just run the 4 data blitzes in succession, and I hope that the authors will then be available afterwards for a few minutes of comments and or questions. So.
Hello, my name is Monet Lulo, and my poster is on perceptions of gender inequality among academic authors of outcomes research. Concerns about implicit bias and the associated risks of unethical or abusive authorship practices have been raised across academic disciplines. Due to these concerns, we examine the association between socio-demographic characteristics and the dimensions of reported difficulty receiving accurate author attribution among academic researchers. We hand-searched 12 months of 12 target outcomes research journals to identify eligible subjects and developed and piloted an online survey to collect data on demographic and career characteristics, as well as 6 dimensions of past author conflicts, including author exclusion, first author demotion, last author demotion, middle author demotion, canceled submissions, or other. Respondents reported the likelihood of these conflicts on a 5-point Likert scale. As illustrated in Figure 1, we identified 12,560 contributors to 1,623 original research papers published in the 1-year period. 267 subjects provided complete survey responses. Our results showed that numerically, more males reported conflicts for most dimensions and were more than 3 times as likely to report a canceled or delayed submission due to disagreement about authorship. In addition, males reported on average 24.7 more publications than females, a difference that was reduced to only 7.1 when controlling for demographic and career characteristics. In conclusion, disputes over authorship are reported by both men and women, but the numbers are larger for males. This may be explained by the greater number of authorship opportunities reported by males, suggesting persistent gender inequality in academic outcomes research. Our findings suggest an enhanced role for educating investigators about ethical authorship and for determining author responsibilities and rankings early to minimize the risk of disputes. Thank you so much for taking your time to view this. Have a great day.
Hello, I'm Shami Conacher, and I'll be talking to you about a sex-based animal model study on methamphetamine misuse at altitude. Our group had done demographic studies showing that substance abuse increases with altitude of residence, and a positive correlation was seen between meth use and mean state altitude. When aligned by state altitude, Rocky Mountain states showed significantly higher rates of meth use versus the other states in the US. Living at altitude involves chronic exposure to hyperbaric hypoxia, and inspired oxygen rates are significantly lower from 2,000 feet onwards, and healthy people in Salt Lake City at 4,500 feet exhibit lower blood oxygen levels and lower forebrain energetic markers versus those at sea level. We therefore asked whether living at altitude poses a biological risk for meth abuse. The model we used is called the conditioned place preference, and this is what the CPP box looks like. There are 2 outer chambers, which are recognized by visual and tactile cues, tactile from the floor. The box has 2 sliding doors here that, when open, allow access to the whole apparatus, and when closed, restrict an animal to 1 chamber, and this is used during drug conditioning. It is a 10-day protocol with daily 30-minute sessions and is used for figuring out chamber preference after drug conditioning. Animals were housed at these 3 altitudes for 2 weeks, and then the CPP test was done for 10 days. The first day of the test is called a pre-test session. The doors are all open and the animal roams around for 30 minutes, and chamber preference is assessed for each individual rat. After this, it comes the conditioning phase. And on day 2, the animal's injected with methamphetamine and put into the non-preferred chamber from the pre-test session and allowed to roam for 30 minutes, restricted to that chamber. Similarly, the saline injection is paired with the preferred chamber on odd days. That continues for 8 days and is followed by the CPB test when doors are opened and chamber preference is assessed again. CPP results are measured as test preference. So how much does the rat like or prefer meth? And this is the time in the CPP test that the animal spends in the meth chamber versus the saline chamber. And then test difference, which measures how much does meth liking increase after conditioning. So that's meth preference or time spent in the meth chamber after conditioning minus that from before. So an increase in test preference and difference indicates that meth rewards are higher. In the control group, animals were treated with saline alone, and males and females in the 3 altitude groups did not change behavior at all. So there's no general effect of altitude on CPP behavior. In the meth conditioned CPP, 2 doses of meth were used, and for both doses, females showed an increase in meth preference and meth difference with altitude versus sea level, while males showed no significant change with altitude. We then looked at striatal dopamine by ELISA, and striatal dopamine is involved in processing reward stimuli. We found that in females at altitude, striatal dopamine increased versus those at sea level. And also in females, striatal dopamine increased with time at altitude. And this is shown in these 2 figures. And in males, again, we found no significant difference. So in conclusion, in females, meth liking increases at altitude, possibly due to increased striatal dopamine, and living at altitude may thus pose a biological risk for methamphetamine misuse in females. Thank you very much.
Hello, my name is Kayla, and on behalf of our fantastic team, I would like to thank you for allowing me to share our work on vaccination among young adults from a survey that we conducted from October 2020 through February 2021. The survey was intended to gain insight to attitudes and knowledge about vaccines in general, HPV and HPV vaccination, and COVID-19 immunization intentions among rural young adults 18 to 26 years old, as well as to identify areas for vaccination intervention. This was a web-based online self-service survey. We recruited from researchmatch.org, University of Utah, Intermountain West HPV Vaccination Coalition listservs. We utilized RedCap self-service survey tool. We asked for zip code of residence and limited participation to those in the Mountain West. We had 1,611 participants. Pearson chi-squares tested differences and penalized logistic regression estimated odds using SAS software. We used Daggity.net to create a directed acyclic graph or DAG of our hypothesized relationship between having any doses of the HPV vaccine and intent to obtain a COVID-19 vaccine and other known confounders and effect modifiers. DAGs help to uncover causal mechanisms and to inform model selection. The DAG, along with prior knowledge, identified scientifically meaningful covariates for the models. Note that having a previous COVID-19 test is shown in the DAG as a collider, suggesting bias in estimates adjusting for previous COVID-19 tests. Having health insurance was contrasted with not having any health insurance, and religiosity was defined by frequency of religious services. Time or month of survey is used as a latent variable to measure for unobserved factors that change over time and impact intent to obtain a COVID-19 vaccination. Of the 1,611 participants, 60.4% were from Utah, 54% had received at least one dose of the HPV vaccine, and 72.3% stated intent to get the COVID-19 vaccine when it was made available. Only Montanans on the whole did not intend to get the COVID-19 vaccine at a minus 12.5% point difference. 93.9% of Oregonians plan to get the vaccine, the highest rate of acceptance at 87.8% point difference. In examining demographic characteristics of the study population by COVID-19 vaccination intention, having health insurance, taking the survey during the second half of the study period, having had any prior COVID-19 test, and having had any shots of the HPV vaccine were all associated with intending to obtain a COVID-19 vaccination when made available. We found that after adjusting for gender, age, ethnicity, and time of survey, those who had received any doses of the HPV vaccine had 1.79 times the odds of expressing intent to obtain the COVID-19 vaccine compared with those who had not received any doses of the HPV vaccine, suggesting that the decision-making process for getting an HPV immunization and intending to obtain the COVID-19 vaccine are similar. We did not find any effect measure modification, or EMM, by gender, age, ethnicity, or time of survey on the effect of the HPV vaccination receipt and COVID-19 vaccination intent relationship, suggesting that our preferred model contained important confounders for control rather than EMM. Additionally, Model 3 had an 11% increase in estimate, indicating that without adjustments, the estimate is biased toward the null. Results suggest that the decision-making process for HPV immunization and COVID-19 immunization are similar. Only 54.2% of teens in the United States are up to date for the HPV vaccine, and as much as 33.3% of American adults do not intend to get a COVID-19 vaccination. And this area of research is critically needed to understand hesitancy, improve vaccination coverage, and reduce burden of vaccine-preventable illnesses and disease. Thank you very much for your time and allowing me to share our research on behalf of the research team.
Hi everyone, my name is Deanna Powell. I've just completed my Master of Social Work degree, and I'll be co-presenting with Bobby Yance, a second-year doctoral student in the College of Social Work. Today, we will be reviewing results from a survey and focus group and conceptualizing a new model to address gender-based violence by moving from a bystander to an upstander intervention. First, we want to provide some context for structural violence. Structural violence is a concept for a form of violence wherein some social structure or institution may harm people by preventing them from meeting their basic needs. Today, we're narrowing it down to focus on the infectious disease model, with the primary focus on interrupting transmission and spread. So to differentiate, you are probably familiar with a bystander, someone who witnesses an incident of gender-based violence and does not intervene. Our model proposes moving towards an upstander approach, someone who witnesses the same incident but takes action to interrupt.
So next we wanted to go over the preliminary results from a university-wide survey that we conducted to assess how sexual and gender minority women experience gender-based violence at the university level. Here you'll see that we had 211 participants. Of those, 116 identified as heterosexual, while 53 identified as bisexual. Unfortunately, we only had 7 identify as gay or lesbian and 3 identify as pansexual. Therefore, our findings really only speak to how participants who identify as either heterosexual or bisexual experience gender-based violence at the university level. So here we've provided the top 3 types of unwanted sexual contact that participants experienced in the last 12 months. We'll see that those were sexual advances, comments, and jokes, followed by being shown or sent sexual pictures, photos, or videos that were unwanted, and then being pressured to have sexual contact after saying no. We can see with these rates that participants who identified as bisexual experienced all 3 types of unwanted sexual contact at higher rates compared to their heterosexual counterparts. Also, it's worth noting that overall in our survey that participants who identified as bisexual experienced all forms of unwanted sexual contact that we assess for at higher rates compared to their heterosexual counterparts as well. Next, regarding themes from the student focus groups that we held, we found that there were a lack of resources for those who experienced technological forms of gender-based violence. Also, sexual and gender minority women are more vulnerable to gender-based violence. We also found that there was uncertainty regarding how to prevent gender-based violence against other women. And then finally, we found that participants thought there needed to be an ongoing discussion of gender-based violence on the campus, as opposed to just whenever an incident would occur. So our proposed upstandard model to address gender-based violence is based off of the Cure Violence model. Dr. Slitkin developed this infectious disease model after realizing that gun violence spreads similarly to infectious disease, and that if the spread could be disrupted, the overall violence could be decreased. So application of this model to gun violence has actually achieved a 41 to a 73% decrease in shooting and killings in the United States as well as globally. The Cure Violence is an upstandard model since it primarily focuses on identifying people in the community and training them to be upstanders, which will then lead to a shift in norms. So we propose that we would use the Cure Violence action steps to address gender-based violence. Step 1 would be to detect and find, which is where the upstander in the community acts to interrupt transmission of gender-based violence perpetration at the source, ideally before perpetration has occurred. Step 2 would be to prevent future spread, which is where the upstander prevents those exposed to gender-based violence from continuing the spread of violence. And then step 3 would be to shift norms, which is where the upstander may change norms through community engagement, community organizing, as well as training. We wanted to thank you very much for the opportunity to present today and say that we're looking forward to answering questions at the Q&A portion of today's symposium. Thank you.
Well, that was a real live data blitz. A lot of interesting, diverse material in a short order. And to me, it certainly just demonstrates the amazing diversity of sex and gender research that's going on in our community. And I hope that these presentations can spur additional or new collaborations as well. And I again encourage everybody to reach out to either your colleagues or people you've met in the course of this meeting about potential collaborations or questions. We do have a few minutes here for questions, and if we could I'll just throw it open to the group if anybody has questions for any of the Data Blitz presenters. Realizing that we're coming up on 4 hours of nonstop action here, I'll jump in with a tangential question for Dr. Kanikar. Having spent some amount of time with in Tibet, it was clear at very high altitudes that some people clearly have a genetic adaptation to high altitude that most of the rest of us don't. Do you know? I mean, this is outside of your specific research project, but do you know if there's any evidence about addictive potential amongst people of either Tibetan or high altitude South American extraction, either at high altitude or down here at our lower altitude?
I don't know anything. I don't know anything about addiction in those groups. I certainly know that people at extreme high altitude in Peru and in Tibet have been found to have genetic modifications, SNPs in their that allow them to. I think their hemoglobin is adapted for low oxygen, so they use oxygen better in their environment. Now, what they don't seem to show impacts on depression that we have seen across the world at lower altitudes. For instance, in the US, it's been shown that rates of depression increase with moderate altitudes, right? So even at local conditions, 4,500 feet, rates of depression here are significantly higher than at sea level. But that is not seen in populations that are natural residents or inhabitants of extreme high altitude. Now, I don't know anything about substance abuse, but we know for sure that people in the highlands in Peru and Ecuador use coca leaves for high altitude headaches and things like that. And it would be a really interesting thing to look into, you know? So thank you, Michael, for the question.
Well, thank you for a very informative answer. You know, I also had one question for Kyla and or Deanna Kepka, and you know, there's a lot of interest in the whole issue of misinformation or disinformation as it relates to vaccine uptake. Did you have any sense either from other data that you were collecting or just ongoing other data sources, I guess, about how much of the hesitancy might actually be mis or disinformation out there?
Kayla, do you have any insight from your very sophisticated analyses?
Well, I can say that right now we were able to collect a lot of free text responses from our young adult population, and it's a lot. And so we've been working on designing a tool for us to code that data quantitatively, and we're in the middle of doing that. Having looked through it, you know, among the young adults, there do seem to be, you know, geographic differences. However, I'm not sure that I'm seeing, there is more so around the HPV vaccine. There seems to be disinformation, a lot of like personal stories about, I have a friend who's in a wheelchair after having had the vaccine and now I'm afraid to get it. But around the COVID vaccine, I'm not seeing a lot of those responses. It's more seems to be hesitancy and waiting to see kind of how other people fare, waiting to get the recommendation from either their personal physician or from doctors that they trust. But it seems like our young adult, and I think a lot of our young adult population is fairly well educated, and that may be playing a role in that.
And the one follow-up I'd like to say that I didn't actually mention in my presentation is the number one factor that affects whether or not an adolescent or young adult gets the HPV vaccine is if it's strongly recommended by their primary care provider. And so I think we could bump our numbers by leaps and bounds if we just had all healthcare teams strongly and enthusiastically and consistently recommending HPV vaccine when they recommend the other adolescent immunizations. COVID's been a little different, but just stay tuned. We're going to keep collecting data and we'll see what happens.
Right. Great. Any other questions for the Data Blitz presenters? Well, I have to tell everybody that a big part of the reason why this symposium has fallen on Thursday afternoons is because Thursday afternoons still are the educational half days in the OBGYN department at the university, and specifically our grand rounds for a number of years now have fallen on the 4 to 5 o'clock hour, on Thursday, which is by design how it is that the keynote speaker is actually doubling as a grand rounds presentation for the OBGYN department. And this particular introduction is going to be a little bit different from the perspective that I'm not actually introducing the speaker, but I'm going to introduce to you all the person who is going to introduce the speaker. Gail Reber is someone I've come to know over the last probably 5 or 6 years now. And Gail actually has an undergraduate degree from the University of Utah, but has a PhD in epidemiology from the University of Washington, and is also besides having had a remarkable career at the University of Washington, where she's literally mentored a legion of epidemiologists across a wide variety of different disciplines. There's also a VA career scientist, and she and I have had some conversations over the years about how we can expand women's health research and clinical care across the VA and university. And so when I asked her, asked Gail, who would you recommend for a keynote speaker for our Women's Health Symposium, she without hesitation said Andrea LaCroix. And so I'm going to let Gail tell you why she made that recommendation, and I think you'll find that it was a very good one indeed. So Nancy and Leanne, if we could start their recording.
It's a pleasure to introduce my colleague and friend, Andrea LaCroix. She is the Distinguished Professor and the Chief of Epidemiology in the new Herbert Wertheim School of Public Health and Human Longevity Science, University of California, San Diego. Her educational preparation began with a master's and a PhD in epidemiology at the University of North Carolina, and then was followed with a postdoc in cardiovascular epidemiology at the Johns Hopkins University. Her early employment as an epidemiologist for the National Center for Health Statistics and the National Institute on Aging provided her opportunities to work on measurement techniques and participate in early cohort studies of aging. She also made major contributions to science in other institutions, including the University of Washington, Kaiser Group Health Research Institute, and the Fred Hutchinson Cancer Research Center. It was here where she served as the co-project director of the Women's Health Initiative Clinical Coordinating Center, and she continued as a Women's Health Initiative investigator for over 27 years. Dr. LaCroix's scientific research has shifted many paradigms in women's health, in aging, in exercise, and the frailty associated with aging. Dr. LaCroix serves on the board of the Scientific Counselors for the National Institute on Aging and is on a study section for aging and the Clinical Trials Review Panel. She's authored over 500 scientific publications and mentored over 50 doctoral, postdoctoral, fellows, and K awardees. It is my great pleasure to introduce you to Andrea LaCroix, who will address supporting midlife women in the menopause transition, Ms. Flash, and the individualized menopause plans. Andrea?
Thank you so much, Dr. Reiber. And in full disclosure to the audience, I want to note that Dr. Reiber and I are longtime friends, and I'm privileged to have her in my immediate audience today, and have been privileged to have Dr. Reiber as my exercise buddy and my healthy aging buddy. And most especially, I do believe we went through the menopause transition at different times during our friendship. Perhaps some of today's talk will bring back some memories. I want to give you some brief background, which will come as no news to you, that the vast majority of women in midlife experience vasomotor symptoms. Over 38 million US women in the age group 45 to 64. It is not an uncommon symptom to have hot flashes or night sweats. And hot flashes and night sweats is only one of many menopause symptoms that can be experienced, can impact on our daily living in numerous ways, affecting how we work, our social and leisure activities, sleep, mood and concentration, sexual activity, and energy levels. And I can recall walks at Pike Place Market with Dr. Reiber, in which we decided to purchase something exciting. And as I signed the credit card slip, just having sweat drip off my face right onto the credit receipt. But still we survived. So I wanted to first make the point to you that menopause has been very much in the news, and there have been numerous articles that have been published during the pandemic about women's experience of menopause in the isolation of the pandemic. One of these articles, this one on the right by Jackie Gillard, who's from Toronto, talks about what it was like for her to be at home with her family experiencing menopause. I think this is a great article because she articulates that whereas she would have not been so out there with her family having these symptoms, going through this experience with her family all around her enabled them to see what was happening, created some discussion. And ultimately, at the end of the article, she articulates that now that her family knows that she's going through this and that the duration is not too short. I mean, for many women, the menopause transition can take a number of years, that there's just been a more compassionate reception to what she's going through in her family. And I just start with that kind of take on experiencing menopause because a little compassion, although we won't be talking about that specifically as a treatment today, can go a long way in making the transition more comfortable for women at home with their families. So I wanted to start by saying that the background for much of what we'll talk about today does come from the Women's Health Initiative. And the finding from the Women's Health Initiative that estrogen plus progestin in the most common dose that was taken prior to the publication of the earliest WHI findings in 2002 showed a number of risks that we didn't know about before the WHI associated with taking hormone therapy. And before that, we really thought that hormone therapy might be broadly beneficial, including for heart disease. We didn't know for sure about the risks and benefits of breast cancer. And we did know that it likely reduced the risk of fracture. But altogether, this news was unwelcome that there were so many risks. If the WHI had revealed overall broad beneficial preventive effects of taking hormone therapy starting in midlife, we probably wouldn't be having this same conversation today, because if it were safe to take this medicine, it's very effective for hot flashes and night sweats, some other symptoms of menopause. If it were a low risk intervention, it would be not necessary to have investigated all these other ways of treating menopause symptoms. But Bernadine Healy, who was responsible for starting the Women's Health Initiative when she was director of the NIH, recognized the importance of the mixed results from the WHI on risks and benefits. And when she was interviewed in 2011, not too long before her death, she said, "Women have to understand that their health and well-being is affected and determined by personal choices. That includes personal medical choices. There's not one medication or one practice that suits all." And what happened after the WHI was that there was a call to find new ways to manage menopause symptoms so that the repertoire would be greater than just hormone therapy. And so the NIH issued a request for proposals, an RFP, to create a network that would bring together trialists from across the country with expertise in menopause to find new ways to alleviate the most common bothersome symptoms of the menopausal transition by designing and conducting multiple concurrent clinical intervention studies, accommodating a wide scope of populations and intervention strategies. And we competed for that many years ago. Approximately, I'm thinking this happened in 2007 or 8. And we were awarded the network, which we named MSFLASH. MSFLASH stands for Menopause Strategies, Finding Lasting Answers for Symptoms and Health. And so one of the special things about this network is that it was funded by the NIH. And so much of what you hear and read about related to menopause symptoms is really funded by pharma. Women are a huge market for anything that might help with managing menopause symptoms. And very little of that information that we get is from unbiased NIH-funded sources where we're not trying to sell women anything. We're just trying to get rigorous evidence to improve the basis of their decision-making. So this network was funded by several places at NIH. You can see the NICHD, NCAM, the Office of Research on Women's Health, and the main funder, the National Institute on Aging, all collaborated. And then after the first funding period, we competed for an R01 grant to extend this work. And that grant is currently in its second no-cost extension. It's called MSFLASH, Living a Healthy Menopause. And the My Meno Plan digital resource that I'll be sharing with you today is part of this R01, as well as a large, well-conducted vaginal health trial. So the first 3 MSFLASH trials, I'll be showing you some comparative data from these. The first MSFLASH trial looked at escitalopram, SSRI antidepressant, versus placebo. The second one was a 3x2 factorial design, assigning women to exercise or yoga versus a behavioral control group. And for the 2 part of the 3x2 factorial design, assigning them randomly to omega-3 versus placebo. So there's actually 6 different groups in MSFLASH 2. And then in MSFLASH 3, we compared low-dose estradiol or venlafaxine, a SNRI antidepressant, to placebo. And we're now able to combine the results from all 3 of these trials to compare the treatment effects on a variety of menopause symptoms from these studies. We put in place common eligibility criteria to make these joint analyses possible. So all women in the MSFLASH trials are aged 40 to 62 years. They were in the menopause transition or postmenopausal. All of them had to have at least 14 hot flashes per week, so an average of 2 or more per day, with at least some rated as bothersome or severe. They had to be in general good health and sign informed consent. I want to just share with you briefly a couple of special things about the MSFLASH trials. And one of them is that hot flash inclusion criteria. The FDA has a guidance document for pharma that requires an average of 7 or more hot flashes per day for pharma to comply with in their trials of menopause treatments. And when you actually look at the number of hot flashes experienced by midlife women in the United States, it's a very small percentage of the population that experiences 7 or more hot flashes or night sweats per day. And of course, these could be added together. Many, many more women experience a couple a day. So we decided in this NIH-funded network, where we weren't trying to register any new medicines for increasing the market share of anything, that we could be more inclusive. So we set the eligibility criteria at least 14. In Miss Flash 01, we actually started with 28 hot flashes, or an average of 4 per week, still quite a bit lower than the 7 that pharma must comply with. And then we decreased it because it turns out that you're excluding a large number of women, as you could see from the previous slide, who don't even have an average of 4 hot flashes a day. So our common eligibility criteria is quite inclusive of the women who are experiencing vasomotor symptoms. Other differences between these first 3 trials is that trials 1 and 3 on the medications were 8 weeks long, and trial 2 was 12 weeks long. We reasoned that that medical pill interventions would be quicker to influence hot flashes than behavioral interventions like exercise or yoga. We assess vasomotor symptoms with daily diaries every week for studies 1 and 3, the medication studies, but only at 6 and 12 weeks for study 2. And that was because we were asking the women to do yoga or exercise or a behavioral control. And since we were already burdening them with those interventions, we didn't want them to have to complete diaries every day. And then in Miss Flash 2, which was the behavioral trial, we also excluded women with regular exercise or yoga practice so that they would be randomized to something that they weren't already doing. So a few other special things about the Miss Flash network is that when you look at the US data, we know that African-American women have a higher percentage of women experiencing vasomotor symptoms than other race ethnic groups. And we also know that their symptoms are more severe. So it was very important to include African-American and Hispanic women that were severely underrepresented in vasomotor symptom trials before Miss Flash. And you can see in this slide that we succeeded. Our goal was to include half African-American women in Miss Flash 1. And you can see we did have half minority women in Miss Flash 1. And in the other 2 trials, we still had a very healthy representation of African-American women. It was very, very important in our network trials and very uncommon in other trials. So let's just look at some summary of our trial results. In the data that I'm about to show you, we're combining data from 3 or 4 Miss Flash trials in a pooled analysis. This pooled analysis looks at individual level data from all the trials combined using a rigorous statistical methodology, and it accounts for the differences in the trials I've told you about. These are the statistical methods, which I will not go over with you in detail, but you can look at them in our papers and ask questions later if you have them. And that's just a reminder of what 1, 2, and 3 go with, because we're about to look at 1, 2, and 3 as the shorthand for these trials. So here you see the characteristics of women in each of the Miss Flash trials. And the average age was around 54 to 55 in all the trials, but there was definitely spread across this age group. We've already looked at the race ethnicity data. Education was also reasonably diverse. So while there were many women with a college graduate, in some of the trials, half of the women did not have that. In all of the trials, there were some women who were only high school graduates. So lots of diversity. There were plenty of smokers, current and past. Body mass index, like the US, in general. Yesterday or the other day, I read that 70% of Americans are in the overweight or obesity range. That pretty much holds for the Miss Flash trial participants too. Kind of makes you think that we drew the line in the wrong place, doesn't it? But that's a topic for another day. So in terms of menopause status, around 69 to 76% of women were postmenopausal, and the rest were perimenopausal, or we could not determine their menopausal status, likely because of hysterectomy. This just shows you the sites that participated. and the average number of hot flashes in each of these trials. So we're in the trial that had the highest threshold of 28 per week. We got just under 9 hot flashes on average. But in the other 2 trials, also a large number of hot flashes on average daily, 7.6 in MISFlash 02 and 8.1 in MISFlash 3. And these are bother rating scores, very similar across the trials. So let's compare from these trials, what are the effects of these interventions on vasomotor symptom frequency and bother? This slide shows changes from baseline in vasomotor symptom frequency. This is hot flashes and night sweats summarized. And this line here, this dark black line, is the 0 point. So this would mean no change. You can see that for omega-3, it actually didn't reduce hot flashes at all. If anything, it slightly increased them. So omega-3 was our ideal placebo. It just didn't help at all. In the next, you see exercise, also very null. Exercise did not help with hot flashes. It helps with a great many other things, but not with hot flashes and night sweats. And then this green line is yoga. So there was some signal here, tiny, that yoga might help reduce hot flashes. But the winners for vasomotor symptoms were all medications. And so you'll note here that estradiol in the blue line was the most effective, and this is low dose estradiol in MISFlash 03, not the standard dose, was the most effective in reducing hot flashes. And venlafaxine and escitalopram, the 2 antidepressants, were similarly effective. And the other thing to notice about this, though, is that they're not that different. And so when we look at bother, I'll come back with a summary in a minute. We see a similar pattern of results where the medications are the most effective. Here we see that venlafaxine is a little bit less effective than escitalopram, not significantly so, but all these medicines seem to be helpful. And if we look at clinical improvement defined as at least 50% improvement from baseline in vasomotor symptom frequency in the 3 pill trials, we really see very, very comparable results. So at week 4, escitalopram, all 3 of these were resulted in 40 to 44% improvement. And by week 8, we can see that estrogen has edged a tiny bit the this degree of clinical improvement, but these are very, very comparable interventions, something that we didn't know before doing these trials. So in summary, after adjustment for baseline characteristics and outcome values, outcome measures, the effects of all medications were similarly beneficial for vasomotor symptom frequency and bother. And in these trials, all study medications were well tolerated. Let's move on to the second most common and bothersome symptom in the menopause sphere, which is insomnia symptoms and sleep quality. And for this next set of pooled results, joint results, I'm going to show you the data only in women who had an insomnia severity index of at least 12, which identifies women with clinically significant insomnia symptoms. We're able to do that. We use 2 measures in these sleep outcomes. One is the insomnia severity index, which is a very well validated and reliable instrument where the scores range from 0 to 28. And all the data that you'll see coming up is in women that had a score of at least 12. And then we also look at the Pittsburgh Sleep Quality Index called the PSQI. This is a validated measure of subjective sleep quality and sleep disturbances over a 1-month time period. And the global PSQI score range is 0 to 21. To the first 3 MISFlash trials in the data that you're about to see, we add a 4th trial, which was MISFlash 04. And it was a randomized controlled trial of telephone-based cognitive behavioral training for insomnia in midlife women with vasomotor symptoms. And this was published in JAMA Internal Medicine a few years ago. Very good paper, very important paper. And I'll show you, I highly recommend, everything I'm showing you today has been published. Charles Moran is a Canadian who designed CBT for insomnia, cognitive behavioral therapy, and was a close consultant on this project. And this just shows you the design of that telephone-based cognitive behavioral intervention. 53 women were randomly assigned to the cognitive behavioral therapy intervention. The other 53 were randomly assigned to a menopause education control with an equivalent amount of phone time with a counselor. And both groups received this 20 to 30 minute telephone call each week with an interventionist. Both completed daily sleep logs, and both were given a booklet called Menopause Time for a Change from the NIA, and they had group-specific additional reading materials. So that adds another treatment to our graphs here, and it's shown in pink. And what you can immediately see here is, so again, the winner for the least effective intervention is omega-3 tablets. So fish oil not helping us in the red line up here. And the next, everything else had some decrease from baseline. The next lines are for yoga and actually estradiol and exercise, kind of grouping together, but not far away is escitalopram and venlafaxine. So I think we would say that all of these interventions showed a little benefit, but not much. And the clear winner when you compare in joint analyses what helps women with insomnia is cognitive behavioral therapy for insomnia that can be delivered on the telephone. And you can also do it yourself with online programs. We haven't tested that, and we think that being accountable to a telephone counselor is likely much more effective. But we really need to be disseminating and translating this finding right here on CBTI, which could help so many women. And the same pattern of results for sleep quality with the PSCI. You can see that far and away, cognitive behavioral therapy was more beneficial than any other intervention. If we look at the odds ratios of remission to an ISI, an insomnia severity index score less than 8 from where the women started, this just plays out the same way. And we see that omega-3, resulted in no improvement, and that there are these small improvements for all the other interventions, and that the largest amount of remission of insomnia symptoms occurred. The odds ratio, this is an odds ratio of 8-fold compared to the null value if a woman was randomized to CBTI. I think that's really quite phenomenal. And so summary of intervention effects here, CBTI is the most effective intervention for improving insomnia and sleep quality in midlife women bothered by insomnia symptoms. Escitalopram and venlafaxine were modestly effective. Yoga and exercise also potentially helpful for sleep outcomes with small treatment effects. And estradiol's effect on sleep quality was comparable to the other medicines. Now let's talk more broadly again about quality of life. And for this, we use a validated instrument called the MenQual, developed by Hilditch and Lewis. This is 29 questionnaire items. There's an overall score and then 4 domains for vasomotor, psychosocial, physical, and sexual scores within the scale. Each scale score ranges from 1 to 8, with higher scores indicating more symptoms or more bothersome symptoms. And this just shows you the kind of items in each of the subscales. So vasomotor, very much focused on hot flashes and night sweats. They say flushes, the Brits say flushes, and Hilditch and Lewis are Brits, so here you get the flushes. Psychosocial includes anxiety, memory, feeling blue. Physical includes this variety of physical symptoms that women in the midlife complain about. And sexual includes sexual desire, vaginal dryness, and intimacy problems. So when we look at the total MenQual and compare the first 3 MISFLASH trials, what we see clearly here is that estradiol in the total MenQual, estradiol and escitalopram have very comparable and small but beneficial treatment effects. The next most beneficial intervention was actually yoga, and with venlafaxine comparable to yoga at 8 weeks of follow-up, and the other two interventions not helpful for the total men-qual. And when we just look at vasomotor, it won't surprise you to see that even with low-dose estradiol, we get a stronger signal that low-dose estradiol reduced vasomotor symptoms, stronger than for any other intervention. When we look at psychosocial, we see that the two antidepressants, venlafaxine and escitalopram, improve psychosocial the most, that estrogen seemed not to be too helpful with psychosocial problems at 8 weeks, and the other interventions were quite null. And then for physical symptoms, and this is that sort of mixed bag of problems of symptoms that women complain about, we didn't really see a strong signal that any of the interventions were extremely helpful. But it looks like exercise speaks more for the physical than it did for any other thing, and yoga as well. And all the medicine interventions helped a little, just not more than exercise and not more than yoga. And then for sexual, it's kind of funny. Yoga's good for the sexual men-qual. Maybe it makes us more limber. Maybe it makes us have more energy. Maybe it makes us have more libido from just the meditative aspects of it. Estradiol also helpful for the sexual men-qual. The next most was escitalopram, and it's good to see for the sexual men-qual that the two antidepressants did not harm sexual function. So I just point that out here as well. This slide summarizes the magnitude of the intervention effects for all these different things we've talked about. And you can see that the magnitude, these are score changes on average. And you can see that the magnitude is modest. I think it's interesting that even estradiol on vasomotor symptoms is only resulting in a small change on the scale score. But we still think from the qualitative reports about benefits and relief from symptoms that many women appreciated all of these different interventions for different things. So a summary: after adjustment for baseline characteristics and outcome measure values, escitalopram, estradiol, and yoga were modestly effective at improving total men-qual scores. Estradiol was the most effective at improving vasomotor men-qual. Escitalopram was most effective at improving the psychosocial men-qual, and yoga and estradiol were equally effective in improving the sexual men-qual scores. So now I would like to give you a guided tour through showing you a video that Katherine Newton and I made about a week ago about this menopause website, digital resource that we've been working very hard on as part of the current R01. And this is the My Menoplan website. And our goal in this aim of the R01 was to review 25 years, all the available evidence, including the MISFLASH trials, and to develop and pilot test a comprehensive state-of-the-art multimedia digital resource to translate and disseminate rigorous trial evidence, such as what I just showed you, to assist women in making personalized, informed decisions for managing menopause symptoms. So I hope you'll enjoy this guided tour, and we'll come back together when it's over. I apologize in advance for any rockiness getting from the video back to you, but let's take a look at this so that you can see what it is this website is doing. Before I click on the link here to show you the video, I want to say that we're currently in a beta testing phase. We hope to release the website to the internet in 2021, and we are looking for dissemination partners to use this website in a practice setting. If anybody's interested in helping with that in your various practices, I would love to hear from you. So with that, here we go. And I must apologize also for the fact that we are not actors, and so you're getting a guided tour that's two lovely researchers talking about their work without any glitz or polish here. Here we go. This is Andrea LaCroix from Cardiff, California, near San Diego, and we have with us Dr. Katherine Newton from Whidbey Island, near Seattle, Washington. We are preparing this brief video to show you this morning to give you a guided tour of the My Menoplan website. This is aim 2 of our R01, which we've been working on now for several years during this funding cycle. And what the purpose of this mobile resource is to provide a comprehensive and accurate evidence-based resource for women to help them understand and make informed decisions about their plan for managing menopause symptoms. It is also intended to provide healthcare providers and physicians with a way to more easily counsel women going through the menopause transition by allowing them to explore their options before, during, and after their encounters with their physicians. So we hope you enjoy this tour and have a good meeting today. Dr. Newton?
Thanks, Andrea. So I'm delighted to show you our site today. I'm going to share my screen. So this is the opening page of the My Menoplan website with our logo there, our MP logo. And you'll see that the site has 6 landing pages people can go to, in addition to the opening page. And on the opening page, in addition to these pictures of women, women can go to 3 sections. They can go to What is Menopause, our video, and Create Your Menopause Plan, which is really the heart of the program. So we wanted to put those on the opening page. But if they go to the About Menopause section, there are 6 places they can then go. One is a menopause Q&A. We actually have a tool where they can find out what stage of menopause they're in, strategies for talking to their doctor, information for women who've had breast cancer, and we think this is a really unique addition to this site as information for transgender and non-binary people and staying healthy in midlife. The tool allows a woman to go through and answer a series of questions. For example, have you had a period in the last 12 months? What's happening to their cycles? And based on their answers, and we did this based on the STRA criteria, they get an answer about their reproductive stage, and they can also link to the facts. The Staying in Healthy and Midlife Women section lists the kind of areas that you might think about that women might have questions about, but rather than trying to develop these ourselves, we link women to mostly federal sites, the CDC and NIH websites, where they can get more information about these issues. The symptoms page lists all the symptoms here, and women can see them in the pull-down menu, or they can click on the symptoms page. And we've organized symptoms into 3 areas. The 3 most common: vaginal symptoms and other kinds of symptoms. So for example, in the symptoms, if a woman has hot flashes and night sweats, she can click on that. And this symptom page, when it comes up, will show you the format that we used for all our symptom pages. It's being a little pokey right now. Maybe I'll try again. Let me try a different symptom. So if, for example, we show you mood, depression, and anxiety. There we go. On this page, we start out with trying to help women decide if they need to talk to a doctor. But on all the pages, we have what's happening to my body and what to expect, and then treatments that help, that may help, that don't help, that may hurt, etc. And so women can scroll down and see this, and they can link to treatments that we have on our treatments page. They can also complete a diary to track their moods, and they can click on brief screening tools that will give them answers to screening questionnaires and advise them when they need to consider seeing a health professional. Let's see if we can bring up hot flashes. There we go. So here's the hot flash and night sweat page. And again, we talk about what it is, what's happening to their body. There's a diary where they can track their hot flashes if they want. They can print that diary to record their number and how bothered or how severe they thought their hot flashes were, and what to expect, etc. The next landing page is for treatments, and we've grouped those into 6 categories for women to explore. And we group them into prescriptions, supplements, and over-the-counter, things where they really need professional help or might seek professional help, mind-body wellness, other things they can try on their own. And then for symptoms where there were a wide variety of things they might try, but where we hadn't really studied those specifically one at a time, we have symptom pages that list, treatment pages that list things they might try for those symptoms. So for example, if we go to the hormone therapy page, we talk about, first of all, what that treatment is, and then the bottom line that we came to in our reviews, and then we list the symptoms it helps for, may helps for, doesn't help for. We talk about risks and side effects and quality of life and what to do if they want to try that treatment. And on every page, they can print the page if they want, or they can go directly to the Create My Menopause plan page. So this is an example of what we do. Our bottom line doesn't help, and then the symptoms it helps for, that it might help for, that research shows it probably doesn't help for, and potential risks, etc. Another example for treatments might be yoga. Again, so what it is, our bottom line, what it might help for, potential risks, and what to do if they want to try it. And we also say at the bottom what that treatment is not used for or not studied for. And we also, at the bottom of all our pages, have references. The women's stories are still a work in progress, but the Your Meno Plan is really the heart and soul of this website. On this page, women can pick symptoms that they're interested in or that they're having and see what treatments there are in a grid. So for example, if I'm having hot flashes and mood issues, I click on those, and then I get the treatments. I go down, and here it is. It says what treatments may help or are thought to help for those symptoms. So what if I'm not interested in taking any prescription medicines? Or let's say I'm just interested in things I can try on my own, and I've had breast cancer. You can click on those, and it will filter and only show you the things that are appropriate for women who've had breast cancer who are interested in managing those symptoms. And if I'm only interested in treatments that research knows they help, I can click on that and I'll only see the treatments that help. And I can click on any treatment to go see more about it. And women can print this page to take it to their doctor. Other filters that we have are, for example, maybe I'm only interested in mind-body wellness, or I'd like the help of a professional, or I'm only interested in foods, herbs, over the counter. Women can filter by all those things. And the last landing page is who we are. Again, we have 6 sections on this. In our story, we tell women about our background as researchers and why we did this work. And this is where we really stress where our funding comes from. We're not trying to sell people anything, and where our funding came from. If they're interested more in who we are, they can go to Our Team landing page and see us. They can click, for example, they can click on Andrea to find out more about who she is, and we describe more in depth. And we also can go view their academic profile if women are interested. This was actually something they asked for. The women who were in some of our beta testing asked for that. They said, I want to know more about this person. In our video, we tell something about who we are. We describe a little bit about our own menopause experience and why we really wanted to make this site, what we thought is important for women to know.
I'm Andrea LaCroix. Right now I'm Professor and Chief of Epidemiology at the University of California, San Diego. My name is Katherine, and I am a chronic disease epidemiologist.
So I'm Susan Reed. I am currently professor and vice chair for research at the University of Washington in Seattle, Washington.
And my name is Christina Drew, and I'm a general internist.
So we describe ourselves.
To do these kind of studies by proposing the best science. And we just feel so strongly now that the most important thing is that you all benefit from it.
Most women go through it fine. They have some symptoms, but it's a natural event. They're going to get through it and they'll come out of it and they're going to be just fine.
Actually went through menopause natural.
I went through menopause naturally, but I had a hysterectomy when I was 44.
So that gives you an idea of the kinds of stories that we tell on this website and in the video. And then we put all of them as flash publications on this site with links to the PDFs. And we have a section on the science. And this is for women who really are interested in, well, what did you do? How did you decide? So on this site, we talk about the review process and how we reviewed the literature. We talked about how we graded the evidence and more about what we thought was important in how we evaluated the evidence. And then we go into describing about randomized trials, what they are, and the placebo effect, because the placebo effect is such a strong factor in studies on menopause. We thought some women might be interested in knowing more about that, and again, references. And then there's a section where women can contact us, not with medical questions, but if they want to give us feedback about the site or have non-medical questions for us. So that's the My Meno Plan website.
Thank you so much for viewing this very lay video that Katherine and I are sharing with you. We look forward to we look forward to sharing a very refined website. We're still working out little things in beta testing and working on a number of different pilot tests, but we're very excited to share this with women and hope to partner with you to do so. So have a great meeting and come again. Bye-bye. Dale, we're back together and I've stopped everything.
Great.
Hopefully you can hear me. I just want to thank everyone for taking the guided tour of the My Menoplan website, and I look forward to answering your questions and getting back together with you in real life to the extent we're able to. Thank you so much.
And thank both of you very much. Thank you, Gail, for making the introduction to Dr. LaCroix, and Dr. LaCroix, thank you in particular for a terrific presentation. It strikes me that we absolutely could not refuse an offer to volunteer to be a dissemination partner for your study, so we can follow up on that offline. I was interested in one of the things that you mentioned in terms of strategies for talking to your doctor, and there's some interesting data that on average physicians interrupt patients when they're first just trying to describe their symptoms and at about 20 seconds into their attempt. And so does your website give any concrete suggestions on how to get their symptoms or their messages through to their providers?
I don't know without opening it up because there's so much content in that website, but I think that's a great suggestion. What if you get interrupted or don't get to speak? And of course, we welcome your suggestions for what we should say, if you have any. Really, talking about a dynamic that,
right,
a power dynamic that
exactly.
Is really hard to, and it's a societal thing too. So it's hard for women to break in, but we really thought, I'll take a look at that section and make sure that we speak to that. We thought that it would help, particularly if the docs who these women are seeing know about the website. So if it's integrated in practice and the doc wants them to use the website, then if they come showing up with a piece of paper saying, these were the things that interested me, let me tell you about that. Or these are the levels of symptoms that I had, let me tell you about that. That it would produce a more productive discussion. I will say that in my own experience, bringing a piece of paper to my doctor to talk about something, and I'm a pretty educated woman, they don't get much more educated than me, I have been completely frustrated. So I totally understand what you say.
Well, I don't want to hog all the discussion here. Are there other questions or comments from people on the meeting?
Questions about the trials or about the My Menoplan website?
I will. I'll jump in again. Sleep is one of those chicken and egg things. It seems like that. Adequate sleep makes it a lot easier to deal with whatever sort of symptoms we might be having, and lack of sleep tends to make them much more noticeable. Did your studies track the sort of the coexistence or the changes in sleep patterns, and do you have any sense of how much that might actually be a contributor or a co-founder?
Well, one of the interesting things in the CBT trial, and it's published in Sue McCurry's papers, the papers on the CBTI trial, is that the women who were randomized to CBTI who started sleeping better experienced fewer and less bothersome hot flashes and an improvement in menopause-related quality of life. So that was, incredibly gratifying. It not only helped with sleep, but it helped with the whole picture. And it's an incredibly effective intervention. So we've got to figure out a way, like we did on the telephone. It's not hard to do what we did, but we've got to find a way to make easily delivered telephone CBTI available to midlife women. It's hugely beneficial. I ask about it here and I get told, well, refer them to sleep clinic. And I say, well, are there CBTI counselors in sleep clinic? Well, we know about CBTI. I mean, but we need to institutionalize an easy telephone system so that it doesn't cost the healthcare system a fortune. It doesn't cost women a fortune. And you get taken to a place where there's a knowledgeable phone counselor who can lead you through this program.
Maybe one of those things for which telehealth and Zoom may actually be a real benefit as a result
Maybe
of all
breaking the dam of
events.
you've got to come to sleep clinic and have a whole sleep workup and stuff like that. But we had Dr. Moran and Suma Curry trained research interventionists. They were people with master's degrees to do this intervention, and it was way more effective than sleeping pills.
Any questions, comments for Dr. LaCroix? The hazard of being a keynote speaker at the end of 5 nonstop hours is that a lot of people are about zoomed out for the day.
I totally appreciate, but I wish I was there with you. Dr. Varner and I, we tried, we waited a year and it still didn't work out. Who knew we'd be in the middle of a 100-year pandemic? And I hope you all are doing well out there. I can see some of your faces. Be in touch if you want to help with dissemination of this, or you have questions afterwards. You know how to find me.
Indeed. Well, thanks again for a great presentation. I just want to reemphasize a couple of specific thanks from people here at Utah, particularly Leanne Johnston and Nancy Lombardo, who have been behind all of your screens, orchestrating the various presentations, et cetera. We had a virtual symposium a year ago when the Zoom technologies, et cetera, were rather less sophisticated. We learned some important technical lessons, and I really appreciate Leanne and Nancy's efforts. I believe Bob Silver is on the call as our department chair, and I'm going to let Bob take us off.
You bet. Dr. LaCroix, thanks again. That was really interesting and very, very innovative, and I'd love to learn more about it. I just want to thank everybody for participating in this conference. It's really been an honor to host it here, and I think everybody did a really great job of hanging in there with Zoom. We're all just super hopeful that next year we can all do this in person. It was an incredibly diverse array of speakers and topics, and really, really interesting, and again, really went off well. Again, I give my thanks to Leanne and Nancy for just doing a fabulous job of organizing this. I also really want to thank Kathleen Digre, Mike Varner, and Karen Schliep for putting it together. So really great job. Thank you all for hanging in there. Thanks to a great panel of diverse speakers. And let's hope that we can do this next year in person. Thanks all.
Sounds great. Thanks, everybody.